I'm not getting the sharing screening.
Akanksha, you can't screen share? देखो
Yes, ma'am, it's not coming in this screen share.
नहीं वो ग्रीन वाला बटन प्रेस करो
हाँ, green वाला किया मैंने press, ma'am.
Rahul, she can't screen share.
Could you please rejoin the meeting, ma'am?
Better. Okay.
Okay. Good evening, everyone. I welcome you to the webinar of IFS on AMH Demystified. May I start the session with your permission, ma'am?
Yeah.
Okay. The first session is Shweta Vittal ma'am is going to address the session.
श्वेता की CV लगा दो
Ma'am, उनका CV नहीं आया है.
अच्छा, just introduce her. She's secretary IFS.
Ma'am is secretary IFS and
Co-director at Gangaram Hospital. Shweta?
Yeah, hello, good evening.
Yeah.
So it's a nice evening to get together, and the whole program is concentrated on anti-Mullerian hormone. I think there is not a single day, not a single prescription. Most of us are writing AMH, but are we getting any benefit if we are writing it? How to interpret? In fact, I can give a small example. I did an oocyte aspiration for a 40-year-old lady today, and her AMH was written as 3.4 nanograms, though her antral follicle counts were lesser but decent. But her follicular growth was way less than what I had expected, and we got 4 oocytes. So this keeps happening irrespective of the age. And then you start investigating that when was it done, where was it done, what was the correlation, and just an AMH, maybe just an AMH as a standalone marker may not be enough, and we need so many more. So thank you, Dr. Surveen, for curating such a good SIG program where we have such stalwart speakers today. I could see everyone who's listening will gain a lot of knowledge and input about all the details and the minute details about AMH and how to make use of it when you are ordering that test. So thank you very much. And I'm also inviting as Secretary General of Indian Fertility Society to the annual Congress of Fertivision, which will be held on 12th, 13th and 14th of December at Leela Ambience, Gurgaon. A great opportunity again to hear a lot about poor ovarian responders, reserves, sudden hyporesponders, and they are very well curated workshops. So please present your work and be a part of Fertivision. Thank you so much.
Thank you, Shweta. Thanks for coming and representing the center. Thank you so much.
Ma'am, next is going to be addressed by mentor SIG, Dr. K.D. Nair, sir. He is a senior consultant and HOD Akanksha IVF Center. And sir has got 30 international presentations and so many awards to receive. May I proceed, sir?
Thank you. Good evening, ladies and gentlemen. It is a pleasure for me to be here speaking on behalf of SIG Poor Ovarian Responder. All of us are aware that IFS has come up with guidelines on poor ovarian responder, which was a Herculean task. We started this in December 22 when we had the Fertivision in Hyderabad. Then we formed a guidance development group. We included 21 specialists from all over India. And we worked day and night, created a PICO question, created a keyword string. We searched 21,934 articles from the PubMed, Medline, from Google, from everywhere, all the sources, Scopus. And finally, after excluding the various articles which were not relevant, we had narrowed down to 116, which we dug out a full text article, and we made this guideline based on this 160 articles, we had come out with 45 recommendations. All this is there on the website. It was put on the website in the month of May 2024, and July 24, it was released in ASHRAE when we were there. I just want to show you one picture of this ASHRAE, but probably I have to share this thing, so we can leave it. But it has been a landmark effort on part of my colleagues in IFS who have worked on the guidelines, and it remains a reference point for everybody. It has already been accepted by this Human Global Reproductive Health Journal, that is IFF journal, and we plan to publish it in other pub index journal also in maybe very soon. That is all about the guideline, and we give it to Dr. Sureen to carry forward this webinar on poor ovarian responder, the AMH part of it. Yes, Dr. Sureen.
Yeah.
So
So,
Reen ma'am is going to deliver the welcome address. Ma'am is Senior Director and Head IVF and Reproductive Medicine, Max Group of Hospitals. And she is also Professor, School of Health Sciences, University, and
cut it
Vice
short.
President, IFS.
Thank you. Thank you, Akanksha. So, like Sir said, during our year, I think this was very close to my heart, making a guideline with a proper methodology. And that's what we did in our year, where we followed the ASHRAE protocol for guidelines, and we came out with these guidelines. But the idea is not to stop at the guidelines. Why we started these master classes was that we want to dissect every little thing on poor ovarian response or responder. And today we are going to start with AMH, because if we just say ovarian reserve testing, we are again broadening it. So what we are going to do in these master classes is narrow it down and look at it bit by bit. So that is the idea of putting this forward, making it just a master class on AMH. I'd also like to thank all the faculty who's taken out time to make this webinar of a certain standard. All my seniors, my colleagues, thank you so much. Akanksha, you can start.
Thank you, ma'am.
Yeah.
Yes, ma'am. Thank you. Now carrying forward, we have the session on defining and testing AMH levels, keeping in mind the intracycle and physiological variability. I asked the chairpersons, Professor Nalini Sharma sir and Dr. Rupali Goel. Dr. Nalini Sharma sir, he is in SLBS GMC and head of department there in Himachal Pradesh with over 25 years of expertise, and specializes in hydroscopes and advanced gynae surgeries with multiple research articles in PubMed index journals and a life member of various gynae societies. Dr. Rupali Goel, ma'am, she's senior consultant, Department of Obs Gynae, Apollo, and she's at IFS, faculty fellowship ART, Amity University, and got so many awards to her CV and more than 10 chapters in various books and publications. Yes, ma'am, starting the session now.
Yeah, stop screen sharing. Stop your screen share. Just a minute. My screen can be seen?
Yeah.
Yes,
Yes,
ma'am.
can.
We can.
Okay. Right. So, defining and testing AMH, I'm starting with an introductory lecture on what are the basics of AMH testing, keeping in mind its variability. So, when you look at AMH, there is a paracrine control and there's an endocrine control of the follicles. Paracrine is GnRH gonadotrophin independent and endocrine is gonadotrophin dependent. AMH is an ovarian hormone expressed in the growing follicles that have undergone recruitment from the primordial follicular pool but have not yet been selected for dominance. That is, they are about 8 mm in size, and that's where AMH is getting formed. So the initial recruitment takes place under the gonadotrophin independent this thing. Since the cohort of small follicles is in equilibrium with the total number of primordial follicles. So this is an equilibrium. The more the primordial follicles, you'll have more small antral follicles. Hence, the AMH actually reflects the ovarian follicular pool. So that's how we make it an ovarian reserve marker. So it is actually a functional ovarian reserve marker because this is the marker which you can actually see that how well the ovary is functioning and how many follicles will it yield. Advantages of assessing it, it is an objective assessment, not subjective like antral follicle count. And a serum AMH of less than 1 nanogram is accepted as a low ovarian reserve. Less than 1.2 is what is seen in the Poseidon. 1.1 is seen in Poseidon, and less than 0.5 is very, very low ovarian reserve. Most sensitive marker of ovarian reserve, least variability, although there is a variability and we are going to talk about it. So AMH and age. Now, how does AMH vary with age? Up to the age of 16 years, AMH levels are clearly positive and are increasing. And it is positively correlated with age. But it is seen that from 25 years onwards, the AMH levels start to decline to undetectable levels at menopause. So AMH is not just a measure of ovarian, but it has a protective role for ovarian reserve. How is that so? How does AMH protect the ovarian reserve? So the rate of primordial follicle activation determines the size of the developing pool, that all we know, which in turn determines how many oocytes are available to be selected for ovulation, right? So that means that how much depletion is going to take place is really dependent on the rate of the primordial follicle activation in that particular cycle. AMH inhibits the primordial follicle recruitment in an FSH independent manner. So it is not FSH dependent, but independently it is acting on the primordial follicle to prevent this recruitment. And this slows the rate at which the ovarian reserve is depleted. The function of AMH actually is to conserve ovarian reserve, but it is sad that the females with the lowest AMH are at the greatest risk of early reserve depletion because since AMH is low, the rate of primordial follicle activation is high and they rapidly deplete their these things. So loss of AMH accelerates the activation of primordial follicles, leading to a premature depletion of ovarian reserve akin to human menopause. Conservation of the ovarian reserve after injection of a recombinant AMH into young mice has also been observed. So there have been animal studies where they have injected the mice and they've conserved the ovarian reserve. So there is a future therapeutic role of AMH. So this was just covering the physiology. Now, AMH assays, what is the problem? There is a wide variation in the population characteristics. How can we take out an assay when we are measuring AMH only in infertile? Or a smoker may have a lower AMH. So how there is too much of variability in the general population to take out one graph which says that, okay, this is the normal assay. Then if you look at it, the AMH for the fertile population is much higher than that of the infertile population. That is the blue line. The differences between assays depending on AMH levels again remains puzzling and contribute to conflicting results in clinical studies. That's another thing. And a lack of international AMH standard even after 20 years is what is preventing us from getting some kind of a chart for AMH assays. Absence of uniformly calibrated assays limit the development of a standardized AMH cutoff. So this lecture was also on cutoffs high and low, and there is actually no standard cutoff which has been recognized. Although Poseidon does divide it into low as 1.1. Now, getting to know the AMH assays. What are these assays we are talking about? Let's see. ELISA was the first assay which came out in 1995, and it was from DSL and Immunotech. And then came the Gen 2, and this was a manual assay which came in. Its reliability was questioned due to poor assay reproducibility, particularly following sample dilution and sample storage under different conditions. They found that the frozen samples at minus 20 degrees and minus 80 degrees gave a significantly lower AMH value compared with the freshly collected samples. So it really depended on how the sample was stored. Samples left at room temperature for varying periods increased it by 20 to 60%. So if you're collecting samples from the periphery and leaving them at room temperature, you are probably getting an erroneous AMH. And that is the whole problem of taking out a graph of normal AMH in a population, especially in India. Immunoassays are now available both as automated and manual formats. With the automated platforms, they show us superior assay characteristics. So if you look at it, the limit of detection is 0.02 and 0.01 in automated. In the manual, it goes even beyond to 0.0013 and 0.023. The pico AMH and ultra sensitive AMH from UNSLAB are very, very sensitive, although they are manual assays. They are now available for situations where AMH serum concentrations are low, as seen in young women following chemotherapy and in women approaching menopause. So these ones are very, very sensitive. The modified Gen 2, which I was talking about, the ultra-sensitive AMH enzyme-linked ELISA and the PICO AMH, both have an improved sensitivity in the low range. This difference in sensitivity may be of clinical importance when assessing serum AMH, particularly in cases of low ovarian reserve. So you have to have a very sensitive assay for those who have a low ovarian reserve. Currently, the two automated AMH assays, differences in values could be explained because of different antibody pairs. So there is still an error in these, and that may be because of different antibody pairs, and there may be a sample instability still occurring with these assays. So a lot needs to be done on assays. To properly interpret AMH levels, knowledge of the factors that influence AMH levels is crucial. Variability of AMH is what we need to know. We start with ethnicity. How is it different in various ethnic groups? We all know that Indian women have a much lower AMH compared to their Western counterparts, or they have a low ovarian reserve, or they reach menopause much before. Although peak AMH levels at 25 years was higher for Chinese women compared to European, the age-related decline in Chinese women was greater, leading to a 28% and 80% lower AMH at 30 and 45 years respectively. So it's not just the peak AMH we're looking at also the rate of decline. The Indian, Afro-American and Hispanic women appear to have a 25% lower AMH compared to the white women, but with a slow age-dependent decline. There is also a seasonal variability, and this was a paper from 2023, which showed they studied over 2,000 women from 19 to 40 years. What they found was that in the younger women, there was no seasonal variability till about 30 years. But 30 to 40 years, a seasonal pattern was observed where higher AMH levels were seen in spring and autumn months, where there was a moderate sun exposure. The sun, people were more likely to go out in the sun. And this helped in the AMH levels. What they say is that this seasonal variability is related to vitamin D. So vitamin D levels exhibit higher levels in the summer, and AMH levels in women of reproductive age are shown to be lower by 18% in the winter than summer months. It was also seen that a single dose of vitamin D within 24 hours, the serum AMH rose sharply to 15 nanogram from 1.2 nanomoles. So vitamin D has a very active role in the AMH, this thing. That is why they say that with low ovarian reserve, whenever you're starting stimulation, check the vitamin D levels and give them vitamin D. It acts on the granulosa cell apoptosis rather than directly regulating the AMH. So it is acting at the granulosa cell levels. AMH cutoffs for warning of decreased ovarian reserve based on menstrual. Now, it's very interesting that it is also seen that there is variability where women have a different menstrual cycle length. So in young women, this was a study conducted in young women from 22 to 35 years. And the AMH cutoff values corresponding to the onset of decreased ovarian reserve varied according to menstrual length. So menstrual length of 21 to 25 days, onset of decreased ovarian response was seen at 3.5 nanograms. But if they had longer cycles of 26 to 35 days, onset of decrease cutoff was 2.7 nanograms. So shorter cycles, we are cutting off at a higher AMH level, whereas longer cycles, it is at a lower. So most women who have a decreased ovarian reserve also have shorter cycles. Those who do not, probably the AMH cutoff for a poor response should be lowered. Concordance and discordance with AFC and AMH. AMH and AFC values reported in literature are very variable, thus creating difficulties for clinicians to select cutoffs for them. It was seen in this particular study of 2022 that the concordance between AFC and AMH among poor responders was only 30% whenever they were stimulating a patient. So that means that 30% of the patients had both low AMH and low antral follicle. Correlation between AMH and antral follicle was very poor in the range of poor responders. Serum AMH levels declined by 5% a year and antral follicle count by 4% a year. But they saw that when patients had successive cycles, the reproducibility of AMH seemed better than that of antral follicle count. So the intercycle variability was lesser in AMH compared to antral follicle count. What is the validity time of AMH? We've tested the AMH, we've done one cycle, and after 8 months, we're doing another cycle. Do we need to do an AMH? No. What they've said is that up to 12 months, you can make do with the same AMH because the response is going to be similar. But if your AMH is more than 12 months old, you need to do it again. What about the impact of oral contraceptives on AMH? The long-term OCP users showed a AMH decline from 14% to 55%, showing that there was a suppressive effect of these hormones. A decline in antral follicle count strongly suggested that the change in serum AMH levels caused by hormonal contraception was a change in the follicular dynamics. That means it was impacting the follicles rather than a direct effect on the AMH gene regulation. Dose duration or dose of the pill, does it make a difference? The reduction was more pronounced with increasing duration. Like if it was, let's say, 1 year of oral contraceptive, it was much more than 2 months. But there was no dose response between the two. That means the dose of ethinyl estradiol could be higher or lower. It would not change the impact on AMH. Does AMH recover on stopping the pill and how long after? Increase in AMH levels by 30% after cessation of oral contraceptive pill was found months after the last pill. So it does recover. It's not a permanent thing. So AMH is not an accurate predictor of ovarian reserve in long-term hormonal contraceptive users. What about BMI? There was no correlation with antral follicle count. BMI did not change the antral follicle count. Hence, they said that the AMH may have may be directly affected and not through follicular dynamics. And they found that the body mass index negatively influenced the AMH levels, but there are conflicting results on this report. And the degree to which obesity may negatively impact AMH in healthy women with regular cycles should be deemed uncertain at this time. That is the conclusion. Pregnancy suppresses AMH, especially in the second and third trimester, and that may be either because of ovarian quiescence, as there is reduced follicular maturation, or it could be the pregnancy hemodilution and increased plasma protein binding. So remember, whenever you're doing it on a pregnant patient, the AMH, you have to understand it may be suppressed. AMH intra-individual variability, long-term, short-term, and ultra-short-term. So there is an intra-individual variability. It could be long-term, that is AMH that occurs year after year. That is, it could be the normal decline which is occurring. Short-term would be from cycle to cycle. Intermenstrual, you've done AMH and after 2 months you're doing it again. They found a 13% variability, which is low. Ultra short-term variability is a day-to-day variability where you may do it on day 5 of the cycle and then do it on day 15 and it may be different. And this they found in some cases it was as high as 80%. So the variability, serum AMH demonstrated less individual intra and intercycle variability than antral follicle count. So that is why it in many ways is considered a more reliable and robust marker. The high inter-individual variability of AMH makes it an ideal candidate for biomarkers, because what you're seeing is that it can predict diagnostic, prognostic, and other clinical purposes. You can use it as one individual may show lower AMH, and that shows that yes, there is a prognostication on this patient that she is of low ovarian reserve. So the inter-individual variability is where we divide them into the various prognostic and groups and the treatment accordingly. Reporting reduced AMH levels in smokers versus non-smokers, and others reporting similar values in both groups. So again, smokers versus non-smokers, AMH definitely does decrease, but there are some papers which say it doesn't. Intracycle variability of serum AMH were larger than intercycle variability. So intercycle, if you do it one cycle after the other on the same day, it may be the same. But if you do it on different days in the same cycle, you might find a variability. A significant cycle-to-cycle variation in AMH levels was observed with a median variation of 43%. Normal responders exhibited a mean change of 0.6, whereas poor responders of 0.8. So the variability was more in the normal responders and even in the younger patients, as we'll see. Now, what is the nadir of AMH expression which coincides with the greatest follicular growth? So as the follicle is growing, you see that the AMH levels are decreasing, and at ovulation they are least. So when the follicle becomes of a larger size, it stops secreting the AMH. It's only the 8 mm follicles which are secreting the AMH. The luteal phase AMH rises, representing gonadotrophic independent growth of preantral follicles and small antral follicles. So there is a nadir here at the time of ovulation, when there is a maximum follicular growth and the follicle stops secreting AMH or decreases the AMH, and then gradually it starts increasing again when the preantral and small antral follicles start growing. The variation in serum AMH not large enough to warrant a change in the current. Now, this variation is not large enough that we change our practice, that she has to only get AMH done on day 2. She can get it done on any day. This variation is very, very little. Now, this was a study that found that up to 50% of women presenting for fertility therapy had AMH levels which crossed clinical decision points when AMH was measured throughout spontaneous unstimulated menstrual cycles. So they are saying that no, it is changing clinical decisions if you're doing it in follicular phase or in luteal phase. This study also found that AMH levels were significantly higher in follicular phase and pre-ovulatory compared to luteal phases. Fluctuation in the menstrual cycle appears random and minor. This suggests that in clinical practice, AMH can be measured independently of the cycle. It finally concluded that when they found that yes, there is the study found that 50% women were showing an acute rise or depression, and that clinical decisions could be changed when they actually studied it. And this is a cycle from one woman. Look at the variability of various cycles. Now, each of the line is representing a different cycle. And one cycle is showing it to be absolutely flat. The other is showing it to be up and down. There's another one which is showing it to be down, then up, then down. So they decided that this is random, and it's not so much that we should be changing our clinical practice here. Here again, you can see that, look, one of them is totally straight. Some are less curved. So this is from one subject. Does intracycle variability depend on age? So now this was done on different age groups. If you see age 20, that is the one right on top, and age more than 35 is right below. So what is happening? The variability is decreasing. That is what we found in the original paper, which showed a 0.6 variability in the younger and normal ovarian reserve and a 0.28 in the poor ovarian reserve. So as the woman grows older, this cycle, intra-cycle variability, that yes, in the follicular phase it is higher, then there is a nadir just before ovulation, and then it starts rising. This goes with age. It's not there. So it's postulated that the measured serum AMH levels reflect the recruited follicle pool rather than the overall number of primordial follicles. So that is why probably, since the recruited follicular pool is higher in younger women, it is showing a variation, whereas it is lower in older women, and hence it is not showing a variation. Understanding where variability becomes important. 2 menstrual cycle patterns of AMH. The aging ovary pattern included low AMH levels with very little variation, and interpretation could be made independent of the day of collection across the menstrual cycle. So you don't need to bother, tell her to come on any day and get it done. The younger ovary pattern included more than 1 nanogram per ml of AMH with significant variation, impacts on the discriminatory capability of diagnostic and predictive tests. So what is this telling us? This is telling us that if it is a younger woman with a good AMH, and the AMH is falling in a range where your decision may change, then the interpretation of AMH is contingent on the day of the menstrual. Then you have to look at the day of the menstrual cycle. So in a younger woman with a good AMH, please look, was it follicular phase? Was it luteal phase? Was it pre-ovulatory? Because there is going to be a variability. And if this particular AMH level is changing your clinical decisions, you need to see it again at which part of the cycle has it been taken. But in an older woman, because there's no variability, you don't need to bother about this. Which assay should sample be timed and in whom? In cases where ovarian reserve is low, more sensitive AMH assays are needed. And depending on its application, standardizing the serum collection time in the cycle would appear to be a wise prerequisite in some situations. What are those situations? Where the woman is younger and maybe we are looking to see whether the AMH is normal or has it gone low. There you need to look at the follicular phase and the luteal phase. There you can probably do an early follicular phase collection, because that would standardize things. If a woman does not have a natural cycle, then a random sample would be acceptable. Why is variability, understanding it, important? Because limiting effects on the main current application of AMH as a predictive test in IVF, we need to understand that it can be variable, and because of that variability, where if we do not take it into the picture, we could misclassify a normal responder into a poor responder and a poor into a normal responder and give erroneous treatment. AMH still remains the most reliable hormone predictor and can be randomly measured. But we all have to understand that AMH is not a predictor of pregnancy. It is only a predictor of the ovarian reserve and the number of eggs you may get. How does AMH and predicting ovarian health help us actually? It allows different reproductive choices, such as you can tell a woman who's not married to freeze her eggs, or a woman who's not planning children to have freeze her embryos. And it also puts into place appropriate strategies for symptomatic management, emotional support, and risk reduction of bone health and hormonal health, cardiovascular health, and neoplasms for women who are reaching early menopause. These could be the premature ovarian fragile, Turner's syndrome. What is the psychological impact of ovarian reserve testing? Definitely has a negative psychological effect, because she could just be a normal woman walking into your OPD saying, I haven't conceived for 6 months. You do an AMH and you tell her, oh, your egg reserve is equivalent to what should be at 40 years. It is a definite negative psychological impact. And we don't realize that AMH is not a predictor of pregnancy. Cannot reliably be used to predict those who may have difficulty in conceiving or timing of an individual menopause. So you cannot say your menopause is going to reach in this many years, even with the AMH, because there is a variability. The rate of decline may be less in one patient, maybe more in the other. And hence you need to understand the significant limitations that affect the interpretation. Lastly, should combined testing of ovarian reserve be done? Extremely low AMH should not be used to refuse treatment in IVF. If she's come with, let's say, a very low AMH and she wants to go ahead with her egg, especially if she's a younger woman, you need to counsel her and tell her that we might get less eggs, but pregnancy is still possible. So that is one of the most important things we have to understand about AMH. The last thing is the direct to consumer ovarian reserve tests. These have come into play, and what are they doing? They are causing a false security. So either a false security or a false insecurity, which patients are just buying these tests and testing it. There is no logic behind it. So basically, any woman who's we don't have it, I think, in India, but in the West there are direct to consumer ovarian reserve tests, and I would not say that one should depend on them. While AMH and ovarian reserve testing has significant clinical benefits, it also has significant interpretive limitations and can even cause psychological harm. Given this, it is important for providers to be judicious in their use and in their interpretation, and AMH as a guide to ovarian reserve testing, but it is not a predictor of pregnancy, and that is something which we all have to understand. We have to educate our patients. We are not to tell them that, oh, your AMH is so low, you can never get pregnant, because even low AMH women, especially younger ones, get pregnant very easily. So a Rolex keeps time well, but makes a lousy hammer. AMH is merely a tool, and its value relates to the task to which it is applied. So it's very important for us clinicians to understand AMH and to interpret it. Nothing is a straight arrow with fertility. However, early we may detect a poor ovarian reserve, we still have not found the solution. And that is the bottom line for it. Thank you.
Sure. Thank you, madam. This was very insightful and well articulated presentation on the inter and intercyclical physiological variability of AMH testing. You, in detail, you covered all the variables like ratio, seasonal variability, relation with vitamin D, cycle length, impact of OCP. I think there is any thing unanswered which you have kept. So if any question, so it is open for the questions also.
Yes, very nicely stressed, Dr. Sylvine ma'am. Of course, it does not, as very nicely mentioned, a low AMH does not preclude a spontaneous conception also. Yeah, it just merely, it primarily just signifies a low ovarian reserve. And as with all of us, I'm sure today only, I just sometime back, I had this patient who had a young patient, 25-year-old, with infertility and an AMH of 0.6 and 0.628 nanograms per ml. I did an ultrasound for her, and her AFC was what? Good 6 to 8 AFC on one side. So always, take it, very, very clear take-home messages should be there, that you have to interpret AMH along with the AFC, along with the age of the patient, and then only counsel, rather than jumping into any conclusions just primarily on the basis of AMH alone. Yeah.
Akanksha, I think we can go on to the next lecture.
Dr. Akanksha, we can just
Yes.
move to the next talk. We are already, I think, relatively late.
Yeah.
Yes, ma'am.
Just introduce the chairpersons, Akanksha.
Yes, ma'am.
Should I stop my slide sharing?
Dr. Abha, she'll just put on the CVs.
Yeah, I'll just stop my slide sharing. And another thing is, do I still have 20 minutes to talk?
Yes,
Because
absolutely.
my talk time is already finished.
Yours is a star talk. You have 20 minutes.
Okay.
Ma'am, there is some problem ongoing with my.
Okay, you can read out the CVs. You have the CV, Dr. Gauri.
Yes, ma'am. I can read it out.
No, you can do it. I'll stop share. Is my slide still shared, or it is
Yes,
not?
it's still shared.
Okay, so I want to just stop sharing. This is share. And how do I stop share? Is there a button?
Must be a button on top. Just
Okay.
click your cursor on top somewhere.
Yeah, it has to be somewhere on top only. So, no, not here.
हो गया.
हो गया ना? हाँ, ठीक है. So Akanksha, you can share the slides now of the chairpersons.
It's okay. Good evening, everyone. Why are you wasting time? It's already 6:45. So let me, I know I'm honored to present Dr. Abha Majumdar here. She's the head of the Department of ART in Gangaram Hospital, a teacher of teachers and a treasure house of knowledge, and so many awards to her credit. The BC Roy Award, many a Lifetime Achievement Award. She has made many papers she has presented, published. So here we are going to get a talk from Dr. Abha Majumdar on anti-Mullerian hormone is an algorithm for individualized controlled ovarian stimulation. To Dr. Abha, please.
Thank you so much, Gauri, for the kind introduction. And can you see my slides?
Yeah, we can.
So after this extensive talk by Surveen on AMH and its variability and its uses, I'm going to talk on can AMH be and can develop an algorithm for individualized control ovarian stimulation, which is commonly known as ICOS. So we are talking about ICOS and the role of AMH in developing a protocol for ICOS. A little bit of introduction. This is a very common introductory slide of mine. Ever since IVF was born, baby Louis Brown was born, we understood that what is really needed is a single egg, single embryo, and a single baby. However, IVF started to develop fast with the aim of maximizing pregnancy rates per cycle. There was rapid progression of protocols and technology. And what happened as a result? We started doing controlled ovarian hyperstimulation, not stimulation, for higher number of eggs and thus embryos. For that, we use very high doses of gonadotropins, time-consuming long protocols, cost was high, patient discomfort was high, and there was a higher risk of complications. This magic wheel had to slow down, where multiple births, hyperstimulation, lot of money, lot of injections went. We needed better controlled ovarian stimulation. And the definition of success in IVF started shifting from pregnancy rate per cycle towards achieving a live birth rate per standard course of treatment or per cycle of treatment. And hence, for achieving this aim, the first change had to be in ovarian stimulation. We had to carefully individualize controlled ovarian stimulation. So this was further progression of technology to minimize complications yet maintain optimal live birth. Now, this is again a very common slide of mine. Start of IVF started with the use of gonadotropins, then came the agonist, then came the antagonist, then the complication rates had to be made low, and mild stimulation techniques came in the 2000s. And then came the segmentation of cycle where agonist trigger was used, antagonist cycles and freeze all came. So once this came, we became quite safe in our hearts that, oh, we can prevent OHSS. And if we freeze, then we can also lead to a singleton pregnancy. But after that, we still had complications of overstimulation, despite having segmented our IVF cycles. And so came in ICOS, individualized controlled ovarian stimulation, where we modify IVF to combine safety and efficacy both. If we say we took out 30 oocytes and we froze everything, so there is no risk. There is still risk of torsion, of bleeding, and of excessive pain, and the first 8 days of ovarian hyperstimulation. So we cannot say that we have brought in safety to the patient. So just segmentization or segmentalization of a cycle did not lead to complete safety, but ICOS started bringing safety and efficacy both. So now, how did the progression of technology happen? First, there were conventional stimulation protocols. You all understand that we used to use agonist in the beginning. Then we started on antagonist. And we uses good doses of gonadotropin so that cycle cancellation was minimum. We got good number of oocytes and we made good number of embryos. Then came the milder stimulation protocols, which aimed at less than 8 oocytes. But then it needed very good lab conditions. We had to do repeated cycles. So patient had to go IVF multiple times if we did milder stimulation protocols. And then came the era presently, which is there, of individualized controlled ovarian stimulation, which gave us the best live births per initiated cycle, with lower complications in the form of ovarian hyperstimulation and multiple pregnancy. So to practice ICOS, strategies to improve outcomes of ovarian stimulation will depend on all these four, but I am going to only concentrate on expected response, which takes into consideration age, weight, previous response to stimulation, and ovarian reserve test. And AMH is a ovarian reserve test which has been developed last of all other ovarian reserve tests. So when we say age, weight, ovarian reserve test, and previous response, how do we identify response? Well, we'll say this girl is a hyper responder, this girl is a normal responder, and this is a poor responder. So AMH alone is not enough to predict. You just heard Surveen saying that there could be various responses. What we need with that, we need what is her cycle length, and if her cycle length is more, is it because of large ovaries, which probably indicate underlying polycystic ovarian syndrome, or she has regular cycles, normal 7-8 cubic centimeter ovaries, or she's had first longer cycles, first shortening of cycles, now longer cycles, whereas earlier 2 years ago, her cycles were 28 days or 27 days cycle. Then her age is important. Well, we can define 37 or maybe even 35 as a higher age. Then comes FSH levels. Now, AMH alone may not be able to predict the response. FSH levels are very important. And if FSH levels are low with estradiol levels around 50 plus minus 20, we are happy that this is true FSH levels. Similarly, if the levels are up to 12, but more than 8, then we say, okay, this is still a normal cycle. But if they go above 8 with whatever AMH there is, we would say this woman would respond less. Her ovaries are declining in function, and maybe she'll need a higher dose for ICOS. Similarly, AMH, well, I've written in picomoles because all over the world, the estimation is in picomoles more commonly, but 25 picomoles would amount to about 3.4 nanograms. 10 to 25 is about 1.2 to 3.4, and AMH less than 5 picomole is about 0.5. So all said and done, all I'm saying is AMH alone may not be able to predict ICOS, the algorithm for ICOS. You will have to take the age. I didn't bring in obesity here. Probably the weight of the patient is also very important to develop ICOS. So now I'm going to show you a very interesting slide, and I want all of you to look at this. Say a patient comes to you with an AMH of 0.4 nanogram, and you've suddenly picked up your pen and written a basal FSH and estradiol for her. I don't write basal FSH and LH. Instead, I always like to write basal FSH and estradiol. So 80 estradiol is supposed to be the highest estradiol which should be accepted for normal ovulatory response. If it is higher, it only indicates premature selection of the follicle which has started producing high amount of estradiol. So there are 3 situations: basal FSH 18, basal FSH 13, and basal FSH 10 with a constant estradiol. Which situation do you say will respond best and which will respond worst? We'll come to that. Similarly, if AMH is 0.4, menstrual cycles are 26 to 28 days. In another scenario, 23 to 25 days, and in another one, it is 35 to 40 days. Which cycle length will indicate that this patient will respond best in ICOS? And then age, you see 31, 36, and 41. So in the first case, the lowest FSH will indicate that this patient will respond better to these AMH levels, to whatever doses of gonadotropin you've decided. Here, the menstrual cycles being more normal is going to respond best. And here, the youngest age will have the best prognosis in terms to ovarian response. This is what normally which should happen. So AMH alone should not be used as a predictor, and I'll tell you why. In one case, the AMH was like 20 or 30 nanograms, and I told the girl, oh, nobody's been able to induce ovulation for you. Probably they didn't know what to do. Come on, I'll induce. And I started gonadotropin, nothing worked. And then when I did her FSH, it was almost 100. So this was a complete FSH receptor resistance, but even polymorphism will have a higher FSH. And in that case, you will have to increase your doses to be able to stimulate the same woman with the same AMH, with the same age, with a higher dose of gonadotropin. So all I'm saying is AMH is a great predictor. It is a wonderful predictor, and it is there for the last, now I would say, almost 20 years, because my first paper was published. Ruma was my student, and we published it in 2008 or 9. We had just started to do AMH then. So when we stimulate patients, when we talk about individualized controlled ovarian stimulation, we have two problem groups, the poor and the high responder. You see, look at the ovary. The poorest responder is on top and the highest responder is below. So low ovarian reserve, older women will have only a definite number of oocytes, and thus in a cohort. And thus we need to maximize oocyte recovery for these. Whereas the high responder and the young woman is our concern only because we need to prevent hyperstimulation to bring safety to this patient. We have to aim at a good number of oocytes, but these girls still hyper-respond, leading to the risk of OHSS. Hence, we need to control our stimulation. And then is the normal responder group, which is the most convenient group, where you will, on a conventional stimulation, get 10 to 15 oocytes. And this is the best number to get because you can do a fresh and frozen transfer, both in this woman in the months to come. So normal responder, you use a long protocol or you use antagonist protocol. Whether it's flexible, fixed, depends on what you are used to, and use a gonadotropin dose of 225. I would use this, but you can use as much as 300. And you need a good cohort formation pre-controlled ovarian stimulation, because even a normal responder could be a poor responder if the cohort is not good. So this is all for a normal. Then we look at a high responder. Here we prefer, first stimulation protocol is antagonist protocol. In normal, both were equally good, agonist and antagonist. Here, antagonist is the best, agonist trigger is the best, and freeze all embryos if overstimulated. If you've still been able to just stimulate enough to get 10 to 15 oocytes, you can do a fresh plus frozen transfer, both. But if you've given an agonist trigger, you've given it because you thought your stimulation was too much and you don't want her to go into OHSS and you don't want to do a fresh transfer, in that case, you will freeze all embryos. If you think that you've stimulated very, very normally and you're not likely to get more than 13, 14 oocytes, you can give a trigger with a HCG also to these women. All protocols require low starting dose of FSH in between 100 to 200 MIU, and still these girls may get over or understimulated. I gave a patient 50 units for IUI, and after 7 days, her E2 was more than 2000, and she had about 12 follicles surfaced over her. I was very lucky because she agreed to go through IVF, and we converted and we took out 11 oocytes for her. So there is an algorithm which has been developed for dose of FSH. What dose will you use? Depending on age, AMH, and basal FSH. So all include basal FSH, include age when you develop an algorithm. And if you see here, this is the level of FSH starting dose. If the FSH is like 4 international units per liter in her blood, and the age is about 30, and AMH is somewhere around 4. So you can see that if this is there, all you need is to give her, where does it cross? About at 150. You don't need to give her more than 150 FSH starting dose. Similarly, you can use age, AFC, and basal FSH. So here we've replaced AMH with AFC. You've just heard Surveen saying, like AMH can vary with different laboratory conditions, different phases of the cycle. Even AFC can differ in various phases of a cycle or by observer. There could be observer variations also. So here, if you see, if FSH starting dose is again 150, then the FSH is around 4, and the age is again around 30, and AFC is about 15 or 16. So we know that if the AFC is 16, 17, 18, don't start over 150 dose of FSH. Now, when we say OHSS free clinic, then there were 3 steps. One was that you give an antagonist protocol, fewer injections, shorter stimulation, give a agonist trigger. You don't transfer in this because luteal phase defect becomes very common. And if you want to really transfer, you will have to give aggressive luteal support if you do embryo transfer. And cryopreserve all embryos. Does this mean that now we can have as many oocytes and all is safe? Here I want to bring your attention, because still with this, I get patients who say that they've got 25, 30, 35, even in my center, with the minimal dose we've given, like 150 or 200, sometimes we do tend to get more than 20 oocytes. What is the problem of young high responders, even while we apply complete OHSS free strategies, that you thinking that I will freeze all, I will give agonist trigger? There is a drawback and health risk of a large cohort of follicles to the woman undergoing stimulation, which means she will have a lot of pain. And if you have a kin who's undergoing ovarian stimulation, you know how these girls suffer from pain. Painkillers hardly help them for 2 to 3 hours. She could even bleed from one of the punctures because you've aspirated so many follicles and the ovary was extremely vascular. There could be adnexal torsion, and we in our hospital every year sort of face 3, 4 adnexal torsions only because of high stimulation of patients, mostly come from outside, and rarely they could be a thrombotic problem also, a venous thromboembolism also, which is again rare, but it does happen. So please understand, those 8 days where you've not transferred and the patient is in high estrogen levels with whatever you've given to prevent OHSS, still VT can happen. No chance of fresh transfer because too many oocytes are aimed. Freeze-all becomes a rule, which has its own perils. What are the perils of freeze-all? Responsibility and storage of surplus embryos. Now, every year when we ask for more storage cans, we get a hush from our management saying, how many storage cans do you need? You already have 20. And how can we give you more space to put these storage cans? So there is a great responsibility in storing the surplus embryos. Then there have been papers which reported there is macrosomia with frozen embryo transfer, possibly due to epigenetic changes with it antecedent health risk, and possibility of increase in childhood cancers. Well, this has been extensively investigated in the Scandinavian countries, but then one cancer per a lack of births don't really put us into that amount of danger, and hence we still continue to freeze all and transfer. Macrosomia, yes, these children tend to get more, macrosomia is there, and later in life they tend to get diabetic, hypertensive, and suffer from metabolic diseases. So what is adequate? Target number of oocytes should be individualized by age, ovarian reserve, clinical circumstances. There are concerns regarding safety and patient's recovery after excessive stimulations. Best estimate is retrieval of 15 to 20 oocytes in freeze-all cycles. It is a good balance between safety and efficacy. So 15 to 20, if we get 15 or more oocytes, we never do a fresh transfer because we know that this patient is quite stimulated and she might go into OHSS. And counseling tools for individualization of stimulation goals are being developed to increase efficiency of cycles. When is chance of fresh embryo transfer high? If you have stimulated the patient well enough. When planning for fresh transfer, a delicate balance exists between efficacy and safety. Higher number of oocytes may lead to increase in cumulative live birth rate, but also has increased risk of complications when you've aspirated. So in fresh cycles, live birth rate reaches a plateau, even if you go to transfer an embryo in that cycle, if you've recovered more than 15. So the best estimate is 10 to 15. So the moment you cross the Poseidian group, 9 se upar gaya, 10 oocytes are there, up to 15. That's it. The moment you go over 15, we normally should consider these cycles to be freeze all cycle and no fresh transfer should be done. Apart from this, it's very important to see the symptoms of the patient on day 6 when she comes for a blastocyst transfer. Wait for blastocyst transfer in these hyperstimulated women. Do ultrasound to assess the ovarian volume, whether there's any free fluid in the peritoneal cavity. And if all that is there, you can still stop the fresh transfer. Now we come to the most important group, which intrigues all of us, the poor prognosis group. We normally in conventional stimulation use higher dose of FSH. In my hospital, in my unit, all of us use 300 units a day. And you could add LH, HMG to the FSH from whichever day of stimulation you think is okay. Here again, antagonist protocol with a flexible regime is the most popular protocol. Then comes the GnRH agonist long protocol, and this generally is adopted for these women where despite trying to make a good cohort, we are not able to make a good cohort for them, and we get less than what we had expected to get out of these women. So long protocol could be conventional protocol, or we can do a stop or mini protocol, whichever. Then there is protocols to accumulate oocytes because reserve is low. They are poor prognosis group patients. I would say poor reserve patients. We are not talking about just poor prognosis here today. We are talking as AMH being a predictor. So if AMH is low, then these are poor reserve patients. And we know whatever we do, we will not be able to get more than a limited number of oocytes in a cycle. So all type of dual stimulations can be done, whether it is duostim, which is done in the same menstrual cycle, bistim, which is done in 2 follicular phases consecutively, and a duostim fresh has also been started, where a luteal phase stimulation follows a follicular phase stimulation and a fresh transfer of the best embryo out of the 2 cohorts which can be formed. Or you could, for these patients, go for minimal stimulation with repeat cycles. I've not given much emphasis, but even in dual stimulation, you're going for 2-3 stimulations. And hence, if you are a believer of minimal stimulation, then you can do 2-3-4 cycles of minimal stimulation, collect 2 oocytes, and see what embryos you can make. You can combine clomiphene with letrozole with gonadotropins, as was done by Kwong et al. In the Shanghai Protocol, which was first developed by him as the duostim protocol. So pre-treatment for better cohort is very essential in these poor reserve patients. I should not use the word prognosis, poor reserve group. We can give oral contraceptives from day 2 for as little as 14 to as much as 21 days to stop the luteal selection of a follicle, or we can give estradiol valerate 4 milligrams a day in 2 divided doses from day 22 till menses to stop the luteal selection of follicles. Or if we use a progestational agent for 5 days from day 21, we can still, after the end of progesterone, give estradiol for 4 milligram till menses, so that in those 7-8 days which follows progesterone-free period, there is no selection of follicles in that period. Or antagonist for 5 days before expected menses is now again coming back. It was proposed earlier. Now again, with the available of oral antagonist, we have started to use this to suppress selection of follicles in the late luteal phase before we start stimulation in our IVF cycle. So I brought here Poseidon management of poor prognosis patients, but this is group 3 and 4. This is what we are concerned with today because we took AMH as a predictor, and hence AFC and AMH has to be low. And all what we do is, I've already told you in poor reserve, long GnRH agonist protocol or antagonist protocol with E2 or OCP priming, start with recombinant FSH 300 units, and you can add LH and androgens or do duostim. The same is in the older patients. You can add LH and androgens. However, long GnRH protocol has come back only now, and we need more than 12 oocytes for 1 euploid blastocyst. And here we need only 4 to 7 oocytes for 1 euploid blastocyst. This is the difference what age brings into us. that even if you get 4 to 7 oocyte and you can get 1 blastocyst or maybe 2, you will have 1 euploid. But in the older age group, you need 12 or more than 12 oocytes to give you maybe 3, 4 blastocysts out of 1 will be euploid. This is what has been advised by Carlo Elvighi and in the Diostim 3 and 4 group, where they said if the woman is less than 35 or more than 35, is there any role of adjuvant treatment? Totally depends on you, whether you want to give it. In the younger woman, you can use androgens, growth hormone, CoQ, all. But in the older woman, just use androgens and growth hormone. CoQ will have no effect. So having said that, it is again the same 300 units daily of FSH, or you use the long-acting one, and you go ahead with the same protocol like I told you earlier. So multi-cycle approach to controlled ovarian stimulation could improve all the metrics to define success in poor prognosis patients with poor reserve. So what do we have right now? Improve or restore oocyte and embryo competence, especially in advanced maternal age. That will happen. We will get mitochondrial transfers will start for us. We will inject mitochondria of young women into the mitochondrial or cytoplasm of older women. That technique is not very far away, but till then, we need to possibly have more oocytes only by multiple stimulations so that we can have embryos which can make the woman pregnant. This is the stimulation protocol we use in Gangaram. Diostim is very popular. Bistim has also come up now. One of our fellows did a comparison between Diostim and Bistim, and there was maybe a little higher number of blastocysts which we got in dual stimulation, but no significance was found. So Bistim, Diostim both work very well. And when we compare, this is Bistim and this is Diostim Fresh. You can read about this. This is by Raka et al. Published this year, last year only in 2024. And Bistim is the famous this thing protocol by Massini et al. But then it was challenged by Ubaldi. And there are problems, but you can read these and you will find what are the differences in this. Right now, I just wanted to complete the list of what all you can do till we don't have mitochondrial enrichment of the cytoplasm. What can we do? We can do this. So take-home points are desired number of oocyte recovery is the starting point towards success of an IVF cycle. Categorize patients according to expected response to improve outcome of COS to be able to make it individualized COS. Analyze cycles where patients respond differently from expected response, and you separate these patients. Then these are poor prognosis patients. They are not just poor reserve patients. Must combine efficacy with safety in all women, especially in high responders. Cohort formation is very important while using antagonist protocol for low and normal responders both. Because you might convert a normal responder into a low responder only because the cohort was not good. And adjuvant should be the last resort in poor reserve patients to retrieving oocytes. Thank you.
Yeah, thank you, madam. It is always pleasure to listen to Dr. Abha, madam. And madam, you have very nicely summarized ICOS. And when we are considering not only AMH, we have to look into AFC, age, BMI, and all take-home messages are very clear. So I think we can, since we are short of time, we can have questions in the chat box.
Yeah.
Dr.
But you
Surveen.
can have it in the end. Finish
Yeah.
your. I'll come back to the screen again. Just give me a tinkle on the phone because I've got calls to take from patients, and I'll come back.
Yeah, and Dr. Gauri, madam, you would like to add on?
Thank you. Thank you very much, Dr. Abha. That was a master class on ICOS.
Thank you.
And I'm sure all of them are benefited very much, and they might have questions to ask you. Let them put on the chat box or ask you at the end of the session. Thank you very much.
Yeah, thank you, madam, for the wonderful session. Thank you, Dr. Surveen, for the invite. Thank you so much.
Thank you, Leena, for being. Thank you.
Thank you, ma'am. Ma'am, can you stop sharing the slides?
Yeah, I'm trying to do that. I'm just trying. Let me see. Why
Okay,
am I?
ma'am.
Okay, I'll just try. See what is
हो
happening.
गया.
Yeah, na? Huh. हो गया था, मैंने पहले ही कर दिया था उसको।
Okay, ma'am. Ma'am, moving on to the next session. Can you see my slides?
Yeah, we can see, but you have to go to the right CV.
Yes, ma'am. Okay, ma'am.
No, the chairpersons first. Dr. Ritu.
Yes, ma'am. Ma'am, the next session topic is AMH beyond an ovarian reserve marker. The chairperson is Dr. Ritu Khanna, ma'am. She is Director Khanna Medical Fertility Clinic and fertility specialist endoscopic surgeon, chairperson of FOXY, and has got many awards, Dr. B.C. Roy Memorial Award and a Presidential Award also. And she has too many publications to her, 8 books and authorized 10 chapters and many international publications also.
Thank you so much. Thank you, Akaksha.
Thank you, ma'am. Yes, ma'am, you can start now.
Okay. So thank you so much to our mentor, Dr. Kedina sir, Dr. Sureen, Dr. Renu, and Dr. Ankita for having me here on this masterclass. It's a fantastic session. The 2 deliberations, I think we couldn't move out of them. So moving on with the 3rd session, it's a pleasure to invite Dr. Chaitra Naik, who is the founder, Kalpa Clinic and MYIVF.com. She is also the secretary for IFS Karnataka chapter and a visiting consultant to Apollo, Milan, Cloud9 clinics with special interest with poor responders and recurrent implantation failures. She authored multiple textbooks and, of course, articles, and very dynamic and versatile. Dr. Chaitra, so over to you for AMH Beyond Ovarian Reserve Marker.
Thank you, Dr. Ritu, for the kind introduction. And I thank the SIG Poor Responder Committee for inviting me for this talk.
Just a moment, we still need to introduce Dr. Maheshwari. 1 minute.
Oh, okay.
Just read out the CV without displaying. Yeah, display kar do.
Kar lo?
She's just introducing Dr. Maheshwari.
Dr. Maheshwari M. She has got a work experience of over 14 plus years, and she is a senior consultant to reproductive medicine, motherhood, fertility, and IVF center at Bangalore.
Thank you for being on board. Yeah, Chaitra, you can start now.
Yep. Is my screen visible? Hello.
Yes,
Dr.
it's
Chitra, it's
visible.
very much there.
Yeah, thanks.
Yeah.
There.
So today I have an interesting topic, AMH beyond an ovarian reserve marker. As fertility specialists, whenever we hear AMH, the knee-jerk reaction is okay, cycle day non-specific, great for finding out whether this lady will become, what are the prognostication, how do we counsel her about what is the next treatment. I had this interesting task of finding out what is it beyond an ovarian reserve marker. For the next 15 minutes, we deliberate on the clinical application of AMH beyond an ovarian reserve marker, either in the pediatric group or the adult group, both in males and females, and we try understanding whether it makes sense for us to pursue this as a marker further. At the onset, I would want everybody to understand that AMH before birth, the male fetus has a very high AMH, and right from 8th week onwards, the levels continue to be quite high.
whereas in the female fetus, only from the 36th week onwards, the granulosa cell produces AMH, whereas in the male fetus, the Sertoli cell produces from the 8th week onwards, and of course, it continues till birth. The males always have a high AMH compared to the women. We are usually happy with an AMH of 4 or thereabouts, but the men, since we don't usually measure the AMH in men, they are quite in hundreds of picomoles. And this is important because I had an interesting patient where I got confused. So we'll just talk about it in a while. So AMH after birth in females, we know that they are lower than males at birth. They're low during the prepubertal development, rises in early puberty, plateaus by around 20 to 25 years, and there onwards it decreases with ovarian aging. When until menopause, it becomes undetectable. So coming to the pediatric reproductive medicine and the male fertility, what is the role of AMH in individualized, group of people? The graph on the right, it just shows that the males, all the blue ones, have a higher AMH compared to the pink ones who are in women where the AMH is lower. So coming to AMH in the pediatric population, when a child is born, all parents are curious to know whether they have a baby girl or a baby boy. The dilemma comes when the doctor is also unable to say whether the baby is a boy or a girl, because these infants may be born with ambiguous genitalia and we are not sure phenotypically whether they are boys or girls. The commonest cause of a disorder of sexual development is congenital adrenal hyperplasia. It's about 1 in 15,000. It's quite easy to diagnose and treat. Accurate diagnosis and adequate counseling of parents is important in all disorders of sexual development. However, if we realize that this is not a patient with, or this is not a baby with CAH, what else could it be? So the first thing, as always, whenever we have a confusion about male or female, is karyotyping. When we have a baby who is 46XY, that is a genetic male, the second step could probably be to do an AMH. If the AMH is low in a baby who is a genetic male, that means that the Sertoli cells are not working, the testis is not working, so it probably points out to gonadal dysgenesis as there is no Sertoli cell. If the AMH is high and it is a genetic male, but then phenotypically we are not sure whether it looks like a boy or a girl, then it could be a case of androgen insensitivity. If it is a 46XX, that means genetically the baby is a girl, but somehow there are features of male characteristics. It also indicates that there is some amount of testosterone which is being produced. Either there is an ovotestis or there is some presence of testicular tissue. Then the parents have to be counseled accordingly, and probably the testis or the testicular tissue needs to be removed to prevent virilization. If the baby is a genetic boy, and then the second step that we usually do after we find out the karyotype is to do a scan, we find out that there are persistent Mullerian structures. There could be a possible AMH gene mutation. That means there is a low AMH, or there could be a mutation of the receptor itself. That means AMH is high, but the receptor is not working. So the Mullerian agenesis, or rather the Mullerian regression, has not happened. So there is a problem with the receptor. This again needs to be counseled, that there could be some amount of structures which look like the uterus or the fallopian tubes. Ideally, it should be better to remove it rather than keep it. So counseling, genetic counseling at the early age for the parents, not so much for the child because the child is still young, but for the parents is important because they'll have to understand what are the next treatment steps and how do they need to decide whether they need to bring up the child as a boy or a girl, and all those counseling steps need to be done. Coming to the AMH in a reproductive age group. Ovarian reserve testing has been explained in detail. I'll not be talking about that. What about the menopause prediction models? What about the role of AMH in diagnosing a polycystic ovary? Or about how do we counsel with an AMH level for a patient who comes with fertility preservation? Be cautious that none of these have been agreed by any guideline saying, okay, this is the cutoff of AMH at which we predict menopause or we establish a PCOM or a fertility preservation. All of these are work in progress, and that needs to be kept in mind. So ovarian reverse reserve testing, I'm not going to go into the details of this slide. Especially, I just want to remind people that, ideally more than 25 years of age is when we ideally need to test women for their AMH. So coming to AMH and menopause, why are we as fertility specialists bothered about AMH and menopause? Early menopause has got a lot of complications, especially osteoporosis, coronary vascular disease, central adiposity, infertility, where quite a lot of our patients, especially in Bangalore, women start planning their fertility or pregnancy at around 30 to 35 years, more commonly at 35 years, and then they come with an AMH report of 0.5, 0.25, 0.6, and then they are very distressed. They just rethink their life choices. So ideally, we should know how do we counsel and what all needs to be done. So these women again are at risk factor for type 2 diabetes, premature death as well. Early diagnosis and prediction, that is secondary prevention, is important in these women. The average age at menopause is around 49 years, but almost 4% of women have premature ovarian insufficiency, that is less than 40 years of age, they attain menopause, or 8% of women have early menopause, that is less than 45 years. And our government allows women to plan for their pregnancy until 50 years. So these are the young women, at 40 or 35 years who need at least one AMH to understand whether they are at risk for premature menopause, or should they plan for their pregnancy, or at least preserve their ovaries, rather eggs, at an earlier date. The caution is also because classical definition of menopause is a diagnosis which is retrospectively. We wait for 12 months of amenorrhea and the patient does not have a period. We say, okay, fine, this lady attained menopause. And it's not a prospective diagnosis, because at least we could counsel our women saying, okay, this is the time, already the time is ticking, do something about it so that you have your own biological child. This is a very interesting study, which is a systematic review, which was published in the Human Reproduction Update, volume 29. They studied over 3,200, they filtered through 3,200 studies, of which 41 were eligible for about 28,850 women. They found the broad, summary of this entire thing was, if the AMH is undetectable, it approximately correlates for an FSH of 22.5, which more or less suggests that this woman is in menopause. There's a Penn ovarian aging study, which again tried to find out, how many times should you do the AMH and other things. They found out that a lower baseline AMH, and if there is, suppose I do an AMH for a lady at 35, and I do it at 35 and a half, and I find that she has a rapid decline, something which was 1.2 has become 0.5. This is the lady who will go into a rapid decline, and especially she may go into earlier menopause. So if at all, our practice is to repeat an AMH at around 6 months to 1 year in a lady older than 35, and we find out that this lady has got a rapid decline, she would be the person who should be counseled about a quick, earlier planning of fertility treatment. It could be IUI, IVF, freezing eggs, whatever is her choice. There's a small study which did a short-term follow-up, which is what we realistically do. After 3 to 5 years of, duration, they try to find out what is better, AMH or FSH at predicting menopause, and they found that AMH was a better study, a better parameter than FSH for predicting menopause. It is a challenge to diagnose menopause in MRKH patients or those with Mirena or those with hysterectomy, because the classical definition of 12 months of amenorrhea goes out of the window. So if at all we do a prospective study, find out what is the AMH, probably 6 months later, what is the AMH, and if there is a rapid decline or if the AMH becomes quite undetectable, then we suggest to the patient that, okay, you are in menopause, though you don't have a period, but we could suggest hormone replacement therapy or other treatment strategies to prevent the comorbidities of menopause. Coming to the low AMH in a patient with premature ovarian insufficiency, there's an increased risk of POI in a patient with low AMH. Lower the AMH, and there is, of course, when the patient comes to us either with a primary or a secondary amenorrhea, we have found that a lady with a primary amenorrhea has a lower AMH compared to one with a secondary amenorrhea, especially if a lady at 36 years comes with an AMH of less than 1 nanogram per ml, we will have to counsel her about the risk of having an early menopause and ideally go for a treatment, whatever fertility treatment she chooses at an earlier stage. An AMH of less than 0.25 nanogram per ml indicates or implies a premature ovarian insufficiency, but then caution has to be taken because these are fluctuating levels, and even women with less than 0.25 nanogram per ml on an ovarian biopsy have been shown to have follicles. And sometimes we would have counseled them for an egg donor, and then these women may come back pregnant and they will think that this doctor is out to make money. So we'll have to counsel them that maybe you may get a miracle and you may get a natural pregnancy also, but the chance of having a pregnancy with a lower AMH is on the lower side because AMH indicates the number of eggs, but however, it does not indicate the quality of the eggs. So to summarize the AMH and age at menopause prediction, there's an annual decline of around 5.6% per year of AMH from the age of 21 years onwards. Is ovarian aging earlier or faster in India? We probably need some more studies to say yes, ovarian aging is earlier, but practically most of us have felt that our patients respond poorly. They have a lesser number of eggs compared to most of the African or the white population. Prediction of number of years to menopause has been done in 2011 and 2012. The threshold of 2.8 picomoles or 0.39 nanograms per ml, prediction of onset of menopause happens in the next 6 years. And this has a positive predictive value of around 0.9%. In women with 25 to 35 years, the rate of decline per year is around 0.2 nanograms per ml. In the older women, it is just 0.1 nanogram per ml, but the older woman also starts with a lower AMH, so she may reach menopause sooner. So coming to the role of AMH and the role of PCOS, AMH has in humans, it is one of the commonest things. They go to a dermatologist, come back with an AMH report and say, I have got PCOS. So earlier I used to counsel them that see none of the Rotterdam criteria, there are 3 criteria, none of them have AMH as one of the cutoff points or anything of that sort. But now, since more people are doing AMH and most of us do agree that beyond probably 3 or 4 nanogram per this one, if it is high, then probably we should counsel them also. So I think the writing is still on the fence whether we should include AMH or not include AMH. For now, there is no particular recommendation saying, okay, AMH is one of them, but they do consider probably it's, at the borderline that, okay, fine, probably the next guideline, they'll say this is the cutoff. As such, most of us use Roche as an assay, and for us personally, we felt 3.2 nanogram per ml was a good sensitivity where we say beyond 3.2, this patient may hyperrespond. Coming to AMH and PCOS, what is the neuroendocrine hypothesis? If the mother has got maternal PCOS, there is a high maternal AMH level, which causes some neuroendocrine effects, causing hyperactivated GnRH neurons in offspring, and the offspring may result in having PCOS. Now, this slide, I wanted to keep it empty because Dr. Haldar has done a study in AIDS where he felt that there was no difference between those patients with PCOS, PCOM, the polycystic ovarian morphology, and those with hyperandrogenism. The AIDS cutoff, which is personally there, is around beyond 4.1 nanogram per ml, beyond which AIM says that, okay, this is what will show as PCOS. Their normal is 8.5 for PCOS and their normal cutoff is 2.5 for a normoresponder. However, there is a study from China which says those women with polycystic ovarian morphology have a higher AMH compared to those women with just hyperandrogenism. That means that, more number of follicle, more number of primordial follicle produces more AMH. So AMH can also be a marker for pre and post cancer treatment, especially in the granulosa cell tumors. There has been a review of value of AMH measurement in assessing the ovarian function and reproductive potential in women before and after cancer treatment. The pre-treatment AMH measure measurement can predict what is the long-term ovarian function, and it has been found to be better than FSH and age. This improved patient counseling. A patient starts with high AMH and then she goes and undergoes cancer treatment. She will still have a better group of eggs compared to a lady who starts with a lower AMH. So it determines whether fertility preservation strategies may be offered, especially in some cancers where the treatment time to treatment is very less. If she has a better AMH, we'll still counsel her that probably you have a better prognosis. Post-treatment AMH measurements for cancer, it potentially indicates that remaining reproductive lifespan, especially in children, young children. If they have a decent AMH, probably will counsel the parents that yes, the child may still have to continue to have a biological child in the future. It aids in decision concerning suitable adjuvant hormonal therapy, and also it helps in determining the degree of toxicity of different chemotherapy agents. Coming to the study, the patient whom I had a very beautiful looking 25-year-old girl, tall stature. She came from this village near Shumoga. And one of my close friends had done a scan, rather MRI. He said, okay, fine, uterus is not there, but ovaries are fine. So just go to this doctor. She'll do whatever is required. We'll transfer this embryo into a surrogate. Female secondary sexual characteristics were good. External genital was normal. So I just thought, okay, fine, let's do a scan, find out how her ovaries are, and then go ahead with whatever is required. I could not find the ovaries. And then MRI report stated that ovaries are there. So we did an AMH. AMH was 23, E2 was 9, FSH was 16. We sent for a karyotype. We found out that she was 46XY. She was a case of androgen insensitivity syndrome. So we had to do a gonadectomy for her. Explained to the husband that there was some problem with the ovaries. So the ovaries had to be removed. Of course, we could not tell that his beautiful looking wife, whom he had got a love marriage and, you know, all that sacrifice he had done, is a genetic male. So we just counseled them for adoption, and they continue to lead a happy life. This is some 3 years back. So how do we correlate between AMH and FSH? If the AMH is low and the FSH is low, then we need to clinically correlate. If both are normal, nobody is worried. If the AMH is high and the FSH is low, it's again clinical correlation. So there may be chances wherein AMH and FSH don't match. One could be because of cycle to cycle variability. Second could be most important. Generally, when we have seen a mismatch between an AMH and FSH, there's some amount of polymorphism, and that's something that we need to be consciously aware of. And probably most of us just do an AMH. Doing an AFC, FSH, and AMH is not a bad idea to find out if there is a risk of polymorphism, because the patients may not respond to the ideal stimulation as we expect. Coming to the emerging role of AMH in male fertility, this is something which we usually utilize day to day. It's a marker for Sertoli cell function. It's used in pre-pubertal and pediatric patients for diagnosis, especially prognosticating rather. If they have an undescended testis bilaterally, we could just do an AMH and see if there is some tissue which is producing AMH, so that more invasive surgery can be counseled. Counseling for procedures like TESE and the risk of failure can be done very well with AMH. So this is the table of AMH levels and various disorders in male fertility. I'll not be going into details because of time constraints. So coming to the AMH prediction of TESE outcomes, we have found, and this is from a research article, but we personally also have found that if the AMH is on the lower side, especially less than 8 nanogram per ml, the chance of getting good sperms are on the lower side. So this is something which we actively counsel the male partners on. So the contribution of serum AMH in the management of azoospermia and prediction of testicular sperm retrieval, this was done in 155 adult men, and those were the inclusion-exclusion criteria. They found that higher the AMH, better the chances of getting sperms. So the reference values range for fertile men were 14 to 78 picomoles per liter. That means around 1.96 to 10. 100% of sperm retrieval in patients with obstructive sperm. So the cutoff, again, depending on various patients, it varies. But generally, if it is less than 0.35 nanogram per ml, we generally counsel the patient that it's not going to be very useful. So AMH and micro-TSA, this is again a very invasive procedure, and the patient is very hyped up saying, okay, fine, I'll become a father with my own sperms. So just before we go for this invasive procedure, it's ideally better to suggest whether there could be a chance of failure. And how do we predict it? We do it with an AMH. If it is cutoff value of less than 4.6 nanogram per ml for AMH, if it is there, then we have to counsel them accordingly. Coming to AMH prediction in low scores, so there's something called as a Johnson score, wherein the higher the score, there's a better chance of getting, sperms retrieved. If it is 10, then there is a very good chance that sperms will be retrieved. If it is on the lower side, then that means that the chance of getting sperms is lower. There's one more, which is the McLachlan score, wherein the lower score, there's a better chance of getting a sperm retrieval. So going ahead, the prediction of cost and dose, AMH is as such a great individualization, a great, blood test for individualizing the ART protocols. It may also forecast the reproductive life and outcomes. A lower AMH person, both male and female, we may counsel them to do things a bit quicker rather than a person with an adequate AMH. It also helps in evaluating the ovarian function, also for systemic disease and surgery. It does serve as a tumor marker for granulosa cell tumors. It does help in diagnosis of PCOS in addition to the scan and other blood tests that we do. AMH may prognosticate the patient with atherosclerosis risk. And of course, we did discuss about the role in male infertility. Thank you for your patience hearing.
Thank you so much, ma'am. Thank you so much, Chaitra, ma'am. Ma'am is Chapter Secretary, Karnataka IFS, who has also joined hands with SIG, Poor Ovarian Reserve, for this masterclass. So thanks a lot, ma'am.
Thank you.
Thank you. Thank you, Chaitra. I think it was a wonderful presentation. And there was one time when AMH had just scored over, testing of our FSH and all. And now you really opened up a new arena. It's a marker. You said about granulosa cell tumor. I think when there's a recurrence, there's an AMH search 16 months before. So good. We'll be able to know everything. And chemo, radiotherapy, I think induced ovarian damage we can do. And on the basis of this, I think that childhood cancer survivors can be really sent on a right time to the reproductive endocrinologist, and they can really regulate their puberty progression and all. So a new learning and a new open arena. Thank you so much. Thank you.
Dr. Maheshwari, any comments?
It was a nice presentation, ma'am. As always, Chaitra ma'am always studies a lot and gives the right information to everyone. It was nice to be a part of this program.
Okay, thank you so much, Chaitra, for partnering with us on this masterclass from the Karnataka chapter.
Thank you, Dr. Surya, for the opportunity. It was a great learning experience for me too.
And thank you, Yogita also is coming on. Thank you, Himachal chapter. She's the chapter secretary. Thank you for partnering with us.
Thank you so much, ma'am. Thank you.
Akanksha, please introduce. KD, I think, has been introduced.
Yes, ma'am. So moving on to the panel discussion now. We have Dr. Renu Tawar, ma'am. She is Director Professor, IVF, Department of Obs Gynae, MAMC, and visiting fellow at Mercy.
That's all right. Thanks, Akanksha, for that. I think we are running short of time, and you have already shown the slide. That's all right.
And we have our panelist, Dr. Rashmi Sharma, Director, Origin Fertility and IVF, Dr. P. Saxena. She is Director Professor, Unit Head, Lady Hardinge Medical College. Dr. Nisha Bhatnagar. She is Medical Director at Via Fertility and IVF Center. Dr. Yogita Dogra. She is Consultant and Director, Arva IVF, and also, as ma'am said, Chapter Secretary for Himachal Pradesh, and who has joined hands with SIG for Ovarian Reserve for this masterclass. Dr. Achal Agrawal, who is Director Fertility IVF Cloud9, and Dr. Neeti Vijay, Fertility Specialist, Director of Clinic Southex, Avaya Fertility. Thank you, ma'am.
So thank you so much, Akanksha. Can we have sir? KD sir is there. I just
Yeah,
want
yeah.
sir can just start.
Yeah, please.
Ha,
Put
sir.
back. Yeah.
Okay, I'll
Some
just share the
questions.
slide, sir.
Yeah.
Yes, sir. Can you see my slides?
Yes, ma'am. Yes.
Yes, sir. Oh, I think it's gone.
Yes, Dr. Renu. Please
Sir,
go.
just a minute. Haan ji, sir. I don't know where is it. Can you see my slides, sir?
Yes,
Yes.
it's visible.
I can't see them myself. Where are
Slideshow करना है रेनू.
but I can't see.
Just
since-
stop sharing and share again, na?
No, I just was there. I don't. Can you see it now? Yeah.
Yes.
Okay. Okay. Sir, would you like to take the few slides, or I'll start with it, sir?
Yes, start,
Okay, I'll
please,
start,
start.
then you can take
Yeah.
the questions, sir.
Yeah.
Okay. So, good evening to all of you, and I thank sir and Surveen for giving me this opportunity to make a panel along with sir. And sir is so experienced in everything. I think sir has all the answers to all my questions. And so we have all a very good panelist over here. And I think majority of the topic has been covered. There's a lot of talk regarding the essays and then the protocols. And I try to make it some interesting because the challenges we face in our clinical practice. And I pushed some questions in that way. So we all know about this AMH, and that is responsible for the regression of the Mullerian duct in the female fetus. That is all known. I will just skip this. And now everybody is talking so much about AMH. And just see this graph where a lot of things are being done regarding the AMH at the time of birth, childhood, pre-puberty, and see the amount of work which is being done in adulthood, where reserve assessment, and a lot of talk which has been given by Chitra. Again, this has already been shown by Surveen, so I'll just skip it. And everybody, all the students should know that where AMH is working, it is gonadotrope independent, and then where it is gonadotrope sensitive, where we are having the dominance of the follicle. So again, I'll just skip because this has all been talked, but let me tell you that serum AMH levels, if they are declining, that means there is some abnormality of the reproductive system in both the sexes. Regarding this has been already talked by Chitra and Surveen as well, the start of AMH, where it starts in females, then what about it starts in males, and this is a very good diagram which just depicts all this so that you can have an idea. In males around 8 weeks and in females around 36 weeks, the AMH starts to rise. Again, this was a very good picture, which I just thought that they have seen with the mice. And then they are saying that at puberty, just if you see that there are a lot of primordial follicles and the antral follicles. At reproductive age group, again, the primordial follicles, but more of antral follicles are there. And in perimenopausal, just see, and even the size of the ovary enlarges in the reproductive age group. But at perimenopausal, just see, we have less of primordial follicles and less of antral follicles. So the first question is to all the panelists: which established model do you use in clinical practice for estimating the ovarian reserve? I think one by one, anybody can take up. Rashmi, we can start with you.
Yes.
Huh.
Yeah. So basically in my clinical practice, I use AMH and antral follicle count for assessing the ovarian reserve.
Okay.
I like to keep the investigations to minimum. So I am not doing FSH and E2. If AFC and AMH are giving me good enough indicator, then I will go by those tests.
Okay, fair enough. Vicky, what about you?
So in my practice, generally, I'd look at the age of the patient, and also the AFC is and FSH we are doing more commonly, and only in the older age group, or if she's having endometriosis, adenomyosis, just because we do not have AMH as free investigation. So of course, if it's an older age group, I definitely go for AMH. Otherwise, I also look at the age, AFC, AMH, and her previous record to estimate the ovarian reserve.
Okay. What about Neeti? Neeti is there?
Yes,
Neeti,
ma'am.
what about you?
Ma'am, I am using AFC plus AMH to assess the ovarian reserve.
Okay. What about Yogita?
Ma'am, I am using age is the foremost criteria, obviously, and along with that, antral follicle count and AMH in the elderly patients.
Anybody left now? I think one more panelist is there. Hi,
uh,
Nisha. Yeah, please.
I agree with Dr. Peaky totally, because I also use age as the primary criteria, and I do basal FSH and AFC. And if needed, then I go for AMH.
Okay, so when I search the literature, you know.
Hi.
Hi.
Dr. Achal has left.
Hi, Achal. Please. I'm so sorry. What about you?
No. So, AMH and antral follicle count are the gold standards for estimating the ovarian reserve, and it has to be correlated with the age, of course. But many a times we find there is a contradiction in the AMH levels and antral follicle count, because when we do scan ourselves,
Yeah,
we
we'll come
find
to
the
that. We'll come to that. I have that another one. What are you using? You're seeing AMH and AFC or
AMH
anything?
and AFC,
Age,
yes.
age is the most primary.
Yeah, correlated with age, yes.
So
The
overall,
previous records are also very
Yes,
important.
I agree.
You must see
yeah, but
how
we are
she
talking
has
about the
responded.
ovarian reserve right now. It is not the prediction, it's the ovarian reserve we are talking. Okay. So regarding this, the two models are definitely there. That is the AFA and AFA. In A, they are taking the AMH, the age, the FSH, and the AFC count. And in this one, they are not taking the AFC count. So what they have seen in the study is that whatever you do, these are correlated well for the ovarian reserve. You can mismatch them, you can group them together and then see the reserve of the patient. And clinically, I think we do agree in the government sector, we usually see the FC count because AMH is not so freely available. And I do agree when there is a doubt, the patient is young, the FC is less, we do go for an AMH just to tell the patient that these two things are matching or not. And obviously in basal FSH levels, we are also doing over here. So this is what it said. And when they, okay, next. And then they concluded what they did see when they compared the two models, they saw that the clinical pregnancy rate, the live birth rate, and the specific differences in the groups A to D was similar when they predicted using the AFA and the AFA model. So both were equal. You all can use it. So everything is clear that for ovarian reserve, we can match all these things together. If there is no money with the patient, obviously AMH can be excluded. Sir, can you take, you want to take the next question, sir?
Yeah.
KD, sir?
Okay.
Yes.
We have this question coming up, 35-year-old female, AFC 5 to 6 in each ovary, AMH 1.1 nanogram. How can you deal with it? How you will deal with such a patient?
This
Yes,
is
Dr.
for me, sir?
Yeah.
So, sir, it will depend upon for how long the infertility is. If she has come to me just say, let's say just about 6 months or maybe 1 year at marriage, I would definitely want to think about normal try and IUI maybe for 1 or 2 cycles. And if the infertility is long or if there are other factors for IVF, I would definitely advise her IVF for with her self egg. Definitely 1.1 nanogram per ml is not low at all. 35 years age is also not so high. AFC 5 to 6. So if you're able to get maybe 3, 4, 5 good eggs, she has a reasonable chance of getting a baby from her own eggs. I would definitely root for self egg.
Okay. So, ji, sir. So what I wanted to put in this slide is, don't you see a discordancy in this? So which indicator will you see? Which will you think the AFC is better or AMH is better? What will you think?
AFC is better.
So there are.
So it's 11, 10 to 12 is the AFC.
Yes.
So,
Yeah,
yes,
5 to 6 in each ovary.
Better compared to 1.1 nanogram of
So
AMH.
there is a disc. What I
See,
want to tell you is this.
Whenever there is a discrepancy, I have seen that the output correlates more with AMH. You might see more number of follicles on ultrasound, but they may not respond. And the quantity and quality usually goes along with the AMH value.
Yeah, I do agree with you, Anchal. But what you see, I think when AFC is good, you are happy. You know, there are those kind of patients where AFC is, but the stroma is also more. Those are the resistant kind of ovaries where there is a debate. But if you think the ovary is normal size, AFCs are good enough, I think AFC shows a better idea. It is a stronger indicator at times, but there is a controversy in this. But definitely what your eyes see, I think that is a better way rather than AMH, just solely on AMH. So I just took out this study where there's a discordance between antral follicle count and AMH in women undergoing IVF. And what did it say? They definitely say that AMH is positively correlated with antral follicle count, but they wanted to see which indicator is more accurate. Then they took a total of 1,121 infertile women who were undergoing IVF and ICSI, and they divided the patient into 4 groups. One group had that AFC and AMH were in the normal range. Group B had normal AFC and low AMH. And Group C had low AFC and normal AMH, and Group D had both the lower ones. And what did they find in that study? That they say that around 18% there can be a discordance in the AFC and AMH levels. But they saw that the Group B, where the AFC count was better than the AMH, they found the oocyte yield, good quality embryo rate, and clinical pregnancy rate was significantly higher in Group B. So they had come to this inference. The study has been done in 2019, and they came to that maybe AFCs are better than AMH for predicting the poor ovarian response. That
But
is what
did they correlate with age also? Because this is
no,
also
they have
been
no,
yeah,
no, the age,
because age is a very
according to the
important
stratified
criteria in age.
analysis of age, they had taken the age also. And for the category, they had taken all this, but they were seeing that the oocyte was more in the Group B.
Renu, we should also see her menstrual cycle length. And
I agree with you. All these are there.
Yeah.
Everything has to be seen.
Clinical
There is
history, examination, all those things
Yeah.
have to corroborate with this.
Definitely. Everything has to be seen. You cannot miss this. It's just a correlation. At times you do see these things on ultrasound and then AMH. I'm just trying to tell you that maybe AFCs is a better predictor at times.
Yes.
Yeah, I have seen that AFC is a better predictor when the female is young. But as they old, though you see so many antral follicles, we usually retrieve less. They are more towards poor responders.
That is exactly what I was saying, that
Yeah.
you may see more, but when you retrieve and when you see the number of embryos, they are lesser and they will correlate more with the lower AMH level.
I will come to that. Achal, I have a question for that also. I will answer that there. I will answer. It's going to come up. It's going to come up. So that is, and then if they said, if there is a discordance, then what to do? Then they said that you can do a ovarian response prediction index. That means you take the AMH, AFC and divide it by the age of the woman, and maybe then you can become much wiser. So that is the answer for discordant scenarios. Maybe you can become wiser by that.
And Renu, many times the AMH level, if you get it done from one lab, it is different. And for the same patient, so many reports they are having, and they are all varying.
But there is slight differences. Very slight differences are there.
No, I've seen
Basically,
lot of big differences. 2.5.
So that essay problem is there, which Surveen had told us. We have to know that even the laboratory reports are not standardized as yet.
That's
so
true
that is
for
why I was
every
just
test.
trying to emphasize that maybe AFC is better when there is a doubt in discordancy.
I agree.
So the next question is for Dr. Peaky. Do you measure AMH in IUI with the controlled ovarian stimulation protocols? Do you do that, Peaky?
Most of the times I do. If the patient cannot afford, then I rely on AFC and FSH and her menstrual history. I also look at the, if she is definitely having adenomyosis, endometriosis, past history of TB, genital tuberculosis, tubes are not good, blocked, then definitely I will get AMH done. Otherwise, not for all patients, because it is, as you know, already said, it's not available in the hospital, only the patients who are having. But ideally, definitely, I would like to have a AMH, because then only we can determine the stimulating agent and the dose of the gonadotrophins or whatever we are.
So when I searched the literature, Peaky, they said as such there are limited number of studies which are evaluating the role of AMH in IUI management. They're saying usually the treatment, first line treatment, usually IUI with control is done. Cases of unexplained infertility, now oral ovulations are also well good in cases of unexplained infertility. So they said maybe you can, if you want to do it, maybe that AMH will help you in telling the cumulative kind of thing, which is better. Maybe they said if the pre-treatment AMH is higher, maybe that is around 3.7, maybe they have a higher chances of live birth. Maybe that type of counseling can be done, they said. As such, there are limited number of studies. Routinely, people are not doing, but I do agree with you. But if there is some diseased ovary where you want to know the AFCs cannot be clearly seen at times because of endometriosis and all, maybe AMH can be done in those patients.
And then if it is very low, and she has all these multiple factors, then I will not like to waste time in IUI.
Okay.
I will like to do it in FSH. But if it is high, then definitely I will go for AMH.
So
I will like to refer her for IVF. So that way also
Definitely.
it is very important to prognosticate and counsel the patient.
I do agree with you. Sir, can you take this, sir?
Yeah, I think we already discussed
Yes, sir.
which level in male partner. Will it help?
Yeah, yeah.
Who is
Dr. Yogita, sir.
Dr. Yogita?
Yogita, are you there?
Was there?
Yes, 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 ma'am. So,
So
ma'am,
are you doing
in
this,
all male
Yogita?
partners, yeah, in all male partners, I am not measuring AMH levels. Only in select group of population. That's it. Otherwise, just for the male partners who are going to be for selective this thing, testicular sperm extraction or for prognostication purpose only. Otherwise, not in all male partners.
Okay, sir, are you doing, sir?
No, I just want to ask Yogita, are you doing the AMH for males?
No.
Husbands?
No, no, sir.
Till
No,
now,
sir.
we are also not doing.
I am not doing.
Sir, even until unless I was searching this question, then only I came to know. Frankly speaking, I have never done it.
Yeah,
I
when
think,
Renu put this question, then only I thought of AMH in males.
yeah,
And
that was something new which
very
we saw that.
interesting, new thing.
Generally,
Yeah,
we
so
don't do in males.
Yeah.
Generally, we don't do it in males. Until
Yes, sir.
the young boy or a pubertal boy is presenting with certain issues.
Yes, sir.
We don't do AMH in males.
Male partner.
Yes, sir.
Yes.
Even we are not doing, sir.
Yeah,
So,
it can be
regard-
done if there is if there is a gonadal dysgenesis, like if you want to confirm the diagnosis.
Maybe. I do agree with you. When I searched this literature, maybe it is telling us all this. And even just Chitra also told us maybe for that non-obstructive. So I just put these slides, and whether it's going to help us or not, I think that's a lot of debatable issue in this. So they say if the infertile male has an average test of less than 15 ml, they have definitely lower AMH concentrations. Even by the size of the testing, you can think they are going to have a lower AMH. So clinical application is important over here. And they say definitely if they're higher AMH, they have higher sperm counts. This is what has the study been telling us. And then they said in cases of infertile male, they are 60% lower than the control groups. They had seen 82 fertile men and 31 control. So the AMH levels, so majority of these infertile men have lower AMH levels. That is one which I just came to know about all this. And regarding, they said as such serum AMH, I think they said even all these concentrations, that the serum FSH, LH, NMB, testosterone concentration along with AMH should maybe taken the help of all this, and maybe then you can come to some conclusion.
Yeah.
And regarding its role in AMH in sperm recovery rate, I think just Chitra told us, yes, it is coming up in a big way. And this was a study in 23, which whether it was predicting the positive sperm retrieval in men with idiopathic non-obstructive azoospermia. And this was a multicentric cross-sectional study. And they had taken 117 men with idiopathic non-obstructive azoospermia undergoing microtessay at the tertiary hospital. And they could do 51% men had a negative sperm retrieval, and 48% had the positive sperm retrieval. And when they saw the AMH levels in these patients, they saw the patients who had positive retrieval had lower levels of basal AMH, and the threshold they had taken was less than 4. So they were saying that if the AMH is less than 4, they achieve the highest accuracy for a positive sperm retrieval in microdeci. That is the cutoff they had given in the study. I think Chitra was also telling the same thing. So this is the latest which has come up. And again, this was a meta-analysis which has again done regarding the AMH and predicting the sperm retrieval in men with non-obstructed azoospermia. And they were also saying that AMH are significantly decreased. Basically, FSH and inhibin may not tell you, but yes, AMH, if this is lower, maybe that these patients will have some, you can retrieve they have a significant predictive value with lower baseline levels in the positive in patients with sperm retrieval group. So that was the something new which had come up. And even they said that even AMH levels can differentiate between non-obstructive and obstructive azoospermia as well as orchidism and cryptorchidism. They said if the AMH is very low, that means it is more towards a non-obstructive azoospermia in comparison to obstructive azoospermia. And level they have, just that level was told in the sperm retrieval technique.
I think it is something very new, Dr. Renu, that we can do AMH also in cases of patients who are being planned for testicular the sperm retrieval.
Yes.
Generally, we are doing FHS at testosterone level in such
Yes,
cases,
sir.
and
Yes,
we are
sir.
doing ultrasound for the size of testes.
Yes, sir.
We are hardly doing AMH in such cases. We might be putting AMH to use for such a group of patients when we are
Yes,
planning
sir.
surgical sperm retrieval.
Yes, sir, I do agree. I think we should do some thesis kind of thing on this, and then maybe we can become wiser in medical college. Maybe I can put this in a thesis next time, maybe, sir.
More papers need to be done before
Yeah,
we
yeah.
put it in clinical practice.
Sir, you can take this question, sir.
Yeah, 30-year lady, normal ovarian reserve, but does not respond to oral ovulation. How can you treat such a patient in your practice? You give her a lot of clomipene, letrozole, she is not responding.
So
So we need to see if there are other factors. If she is PCO, does she have LH hypersecretion? Does she have hyperandrogenemia? So we need to look at all these factors also, thyroid also. And if all these are taken care of, then we can combine gonadotropins with oral or give her a plain gonadotropin cycle.
Dr. Anchal, she has got normal ovarian reserve. So she is not PCO.
Yes.
She is normal ovarian reserve, she is not PCO, but she is not responding to oral ovulation.
And even to
Sometimes
mild
if the
gonadotropins.
BMI is very high, then also patients may not respond to oral ovulogins. In that case, we might have to give them gonadotropins.
Can anything come to your mind, Achal, regarding this BMI? Everything is normal. Just take it that way, that we have not put that it is not. So even BMI is all right, but she has all this normal reserve, but she is not responding to your drugs which you are giving. You see it so many times when you do. At times you see such patients, I'm telling you.
Maybe I
Then what
think
do
we
you
need
do?
to check other hormones like TSH,
Yeah,
prolactin.
That is all
prolactin,
taken care of. Nisha,
Okay.
that is all
insulin,
normal.
prolactin.
Okay.
And then
That is
she
all
may be
normal.
having polymorphism.
Any
Then
Yes.
the next is polymorphism. definitely.
Polymorphism could be there. No?
But
So
that is
what type of
FSH
what do
polymorphism.
you
We are
call
not
these
giving
OVs?
gonadotropin. This is oral.
No,
Even they
ma'am
don't
said
want
that
to.
she is
will
not
not
responding to
respond,
gonadotropins also. Dr.
Yes,
Renu
yes.
said she is
Yeah.
not responding to
Gonadotropin
gonadotropins
also.
also. Yeah.
At
We have
times
not
they
tried
don't.
gonadotropins here.
Hypo is one condition.
No, but
No,
hypo will give, you
would
give
respond
gonadotropin, she will
beautifully to
respond.
gonadotropins.
She will
Yes,
respond to
yes.
Hypo would respond to gonadotropin.
Yes.
So,
Yes.
Renu, her hormones are normal. That is
Yes.
what you're saying.
Yes,
FSH, LH,
no,
insulin
that's
is
a clinch
normal.
over here. So when the reserve
Yeah.
is normal, what I mean to say, the FSH is all, the AMH is all right, the FC count is all right. I think, and these patients at time, FSH, LH will help you out.
Yes,
When you see
that is
these
very
very
important.
resistant patients and they are
Yeah.
resistant to ovary syndrome, this is known as the
Yeah.
salvage syndrome at all. And they usually come over some of these patients, their FSH, LH gonadotropins will be in the high, they will be in the WHO type 3 category, where the FSH, LH will be somewhere between 20, 30 and all that.
POI category. Right.
Yes. So they are
It
slightly
should not be
different from
POI.
POI, but POI
It
has
should not
normal,
be POI.
also doesn't have AFC normal, but they will have. So this
Yeah.
is what is the pathogenesis of the resistant ovary syndrome. You do see sometimes these are kind of patients, and this is because of the receptor polymorphism or some autoimmune disorders.
Autoimmune
And
is
how,
also okay.
yeah. And they say they do have their pre-ventricle follicles. They are very much present in these patients, but the follicles don't progress to the intral stage. And they have some FSH receptor defect. That is why the FSH is not acting on that receptor, and they do not go towards the intral stage. So how do you treat these patients? If you have.
So
We
high
will-
dose
we-
is one thing. And
What?
then second thing, high dose HMG.
High dose of FSH.
Okay.
HMG,
Correct.
not FSH. It is usually
if-
FSH plus LH we give for these patients. Then second, I have seen that if some patients, there is no response even after giving high dose, they are.
Nisha, it could be only FSH polymorphism also. It is
Yeah.
not necessary that polymorphism of both the things will be there. In poor responders, age is more than 35, 40, then I agree that both need to be given, but it may be just one. So it can be seen whether FSH or both HMG or FSH, recombinant FSH and LH need to be given.
So there
That
are
is
different,
perfect.
so Piki, there are different treatment regimens, they say.
Yeah.
Because already their gonadotropins are very high. So at times you may have to give them oral ovulogins, oral OC pills just to reduce their
Bring it
FSH-LH
down.
levels,
Yeah.
because they are having high FSH-LH. So you have to first reduce them. Maybe you have to give OC pills for 2 or 3 cycles, and then maybe you give them with letrose and HMG. If there is mutation, then that will not help the patient. These patients, but if they do not have any mutation, maybe these things, all these steps which are written here, like combined letrose and HMG may help. They all will not, but some may, and some may get pregnant. Then maybe that I told you higher doses, I do agree with you. People have also used glucocorticoids in these kind of patients. IVM also at times.
Yeah.
Yes, IVM also has been
But
done,
Renu
and
also
even growth
adding a little
hormone.
bit of a little bit of HCG for stimulation also helps in such patients.
But they have
Giving-
not written this in the treatment regimen. This has been published in 2022, and they
Adding
have
a
not
little
about
bit of
HCG at all.
when the stimulation they have stopped, like they are stalled, there is no particular growth. So adding a very small amount of HCG also helps in growth of these follicles.
So I have to see the literature. I have not come across, because I read the whole of this thing. Then none of the studies told about
But
HCG.
Nisha,
Anyway,
HCG small dose is basically LH.
yes,
sir.
Understand?
Yes.
Small dose is basically LH.
Yes.
When we are having this resistant ovarian syndrome,
Yes, sir.
we are probably not responding to a low dose of LH.
So, but sir, when we are giving HMG, we are giving LH also. We are giving FSH and LH. But
Yeah.
still, if there is no growth and we add a little 1200 or 1500 IU of HCG for what I added even for 2 or 3 doses for alternate day, and we see a very beautiful response.
When did you add? When did you add, Nisha? It
So,
is on the day 2, day 3. When
No,
do
no,
you
no,
add
no.
this?
From this, usually I see on the 6th day and the growth is there. Then we see on 8th day, and if there is no growth, the follicle are still at 12, 13 millimeter, despite giving a high dose of HMG. So we add a little bit of HCG for 1 or 2 doses, depending upon the patient. And then we say suddenly there is a growth of the follicles. And there are 2-3 patients which have got pregnant also with this, that we get
Maybe.
beautiful
I
eggs.
don't know, sir. How about you? You have any experience of this, sir? Have you
No,
added, sir?
ovarian syndrome is a very difficult situation to
Yeah.
manage.
Yes, sir.
And
I do agree.
only thing is-
Can I
Yes,
ask?
Yes,
androgens is
Rashmi?
also a good idea. 2 to 3 months of DHEA treatment also helps. Or testosterone gel, if sir had done some studies, some girl had presented, and she showed very good results with testosterone gel. So those 2 things
So
can also
maybe
be tried.
those kind of patients, Picky, they are poor responders,
Yes,
Maybe
yes.
testosterone will help in those kind of patients, not these young
Not in
patients who are 30 years
normal,
old.
no.
And that is why. That is the different kind of group. But I think this was all in the literature which they suggested. And finally, if nothing works, then who's that?
There also, Renu, they have written DHEA, na?
Yeah.
So
I'm
it helps. Because
combined.
DHEA is going to increase the androstenedione, which is the precursor to
Yes, it may
estradiol.
help.
So it may
help.
help.
These are different
The number of
choices.
follicles and all may increase with the DHEA.
So
This is they have given. They are given for 3 months, but nothing is 100% in here.
No, not at all.
Dr. Nisha? Dr. Nisha, you said the doses that you used were 1000 to 1200.
1200 to 1500 IU. Dilute karke na, 5000 ka dilute karke, we give from that only.
This is like that Filicori's protocol, जिसमें कि 200 IU, but वो लोग इस्तेमाल करते रहे हैं.
200 is, I use 1200 to 1500. So, and I give only 2 or 3 doses on the 7th or 9th or 8th or 10th, depending upon those days only.
But I think more of evidence is required, Nisha,
Yes.
with just taking on a long scale, whether we have to really do that. Maybe more of literature and everything. Evidence has to be there for that.
Yes, ma'am.
Sir, you want to say anything, sir?
No,
KD, sir?
that is what I agree with Rashmi. You see, this low dose SIG,
Filicori's protocol, yeah.
it is 150 to 200 units.
Hmm.
We are not giving 1200 to 1500 units. We give,
Okay.
we have used it in few cases, but we give 150 to 200 units. The only problem is how to make this 200 unit from the ampule.
Yeah,
2000.
I dilute that 5000 international unit ampule, sir, and then from there it is easy to give 1200.
So you dilute with how much?
We have not come across the dose of 1200 units in literature.
Yeah,
Probably
Filicori's was
Yes, sir, I can share a paper.
yeah.
Okay, we'll see that. Okay.
Renu have also tried DEXA. 0.5 milligrams
Yeah,
at
yeah,
11 o'clock,
glucocorticoid, they
that
are
also
saying
works
it helps
good.
in these kind of
It
patients because of
sometimes helps.
autoimmune causes, no? That
Yes.
takes care of that at times.
Sometimes it helps.
So I'll not take that AMH and PCO because that has already been covered. So I'll just skip this. Now regarding this, there is debate. So Yogita, can you answer this? When do you measure AMH prior to IVF cycle and does it really matter?
Ma'am, if the patient, most of the times patients are coming with AMH reports. Already they
Yes.
have one or two AMH reports. So if I do a basal scan and if I can see good number of antral follicles, so I'm not repeating the AMH just immediately prior to IVF cycle, just for the uh, uh, doing the AMH level just before.
Yeah.
Yeah, so I'm not doing it unless I am seeing that the antral follicles are on the lesser side, or if the patient is elderly, just doing AMH would be of the prognostic value, basically.
Okay.
I
Anybody
have a
else?
question here. Ma'am, I have a
Huh?
question here. This I keep thinking many times that does a stimulation affect AMH? Like if the patient has already undergone a stimulation and then we do a AMH value, after stimulation, does it declines? Like you have done
Yes.
one or two stimulation and then you do AMH, will that value be?
No, that is not the question. The question is that if you do it in a stimulated cycle, in that very cycle, the AMH tends to decrease because it has a negative effect. But I am asking whether you're prior to starting the IVF cycle, there is a lot of debate in this. So I just put this
Yeah.
slide here. So they said because there is intercycle variation of AMH level, but that is very small and it has very limited clinical importance. So people had done 1 month prior to IVF or as well as at start of ovarian stimulation, and they said nothing matters. There is moderate similar. That doesn't matter whether you do 1 month before or you do at the day of the stimulation. Some people, there's an analysis of 26 cycles where they had done 3 months prior to the index cycle, and they also said there is no systemic variation across the system and it doesn't hold good. They said if you want to really do it, and how will it help? Maybe if you do it in the same day of the cycle where you're starting the gonadotropin, maybe it can just give a response to prediction of the accuracy. That is the only thing, rather than it doesn't help any. So it doesn't matter whether you have done it 2 months or 3 months, rather than wasting money, I think doesn't hold good anywhere. Even the study says that.
Renu, what about 6 months or 1 year? Then I think it should repeat.
That is what they said, no? At least 1 to 2 years, they said. Doesn't want to just say before Chitra had said when to repeat, they said 1 to 2 years. Maybe if the patient is declining elderly, maybe that at times you can just to prognosticate the patient, maybe that is there.
It's 12 months. I had shown that paper, no?
12
Yes,
months, yes,
yes.
ma'am. 1 year.
Generally,
1 year. You
it's
show that.
At least 1 year.
In a woman under 35, you can wait for 1 year to repeat.
Yes, sir.
Above
Yes, sir.
35, you can repeat over even 6 months.
Yes, sir.
Because after 35, the decline is very fast.
Yes, yes, agree.
So anybody agrees with this? Can AMH predict natural pregnancy rate?
No.
No.
Yeah, I think everybody
So I
is
would
saying
like to
that. And this was a systematic review and meta-analysis in 2021. And it also said that serum AMH levels have poor predictive value for natural pregnancy, and even low serum AMH are not associated with reduced fertility. This was a study in around 4,038 women, and 11 studies they had taken.
Can I share a case with you, Dr. Renu? Recently,
Yes.
there was a patient who came blaming and, was sort of fighting with me. That was 7 years of infertility and 0.6 AMH 4 years back. And then her AMH fell to 0.17.
Okay.
I advised her, they belong to very low socioeconomic profile. After a lot of deliberation, they went ahead with donor egg IVF because they could have afforded only one IVF, and that was AMH was 0.17.
Okay.
Unexplained infertility. And we did donor egg. She conceived, had 2 beautiful children. 1 year later, she conceived again, terminated.
Yeah.
And she conceived, terminated. And then she came, madam, you said, they had children with donor egg, 2, and now they had to terminate their self egg at the AMH of 0.17.
Yeah, I'll show you that
6 years
slide
of
again.
infertility.
I'll show you. I'm coming to that, Rashmi. And I do tell you, I never tell the patient whatever AMH they have, that you can never get pregnant. I think we should stop saying this.
Tell them that, but we have to tell them self egg versus donor egg, success rate.
That you can tell. That you can tell.
Yeah, and they decided for donor because they wanted to go for a higher success rate.
And even they had
Yeah,
children.
that you can tell, but never tell them that you can never get pregnant.
Beautiful girl and boy.
Yeah.
But this is what happened.
Yeah, it does happen.
So AMH is not a predictor of pregnancy. That we have to be absolutely clear.
Yes, that is all there. And even they said this study was done, and they said this was a meta-analysis of 13 studies, and they had also done in Chinese women. And they found that something like increasing AMH levels 5 to 7 nanogram per m predicted better cumulative live birth rate. And that was also because of the good oocyte yield may be better. That is what they said. Otherwise, it does not predict the live birth rate. And this was also another optimistic study, which was also saying that on 551 women, and this was done in somewhere lately only the study has been done in 2000. No, that was earlier, 2019. And they also showed that women having older women or low reserve women still had conservative, cumulative live birth rate as high as 37 and 41%. That was too high, I don't know, but that is what they have told in this. So that is the limitation, that it does not have any predictive performance. A threshold value should not be used to deny women from attempting ART, not to be too pessimistic regarding prognosis solely based on AMH level. That's the message the study gave.
I think, Dr. Renu, that is the crux point. Not
Yes,
to
sir.
deny the patient and not to be pessimistic. Whatever
Yes,
might
sir.
be AMH, don't be pessimistic.
Yes, sir. I also agree with you, sir, fully on this. And can AMH predict embryo quality?
No.
All the panelists, yes or no?
No.
No.
Yeah, thank you so much for that answer. And they said, maybe if you want to see the quality, they said oocyte-specific AMH concentration follicular fluid had good prediction on embryonic development and live birth rate rather than serum AMH levels. And that has to be also seen in further studies. So this is the last question. And I think Neeti can take up. A 37-year-old lady, a poor responder, read about PRP and stem cells from Google search and wants to know whether these strategies will help her. Neeti, what do you say on that?
Thank you, ma'am. Ma'am, so I would like to know more about the history of this patient. First of all, whether she is Posidon group 2 or Posidon group 4.
She's a poor responder. Just take it, whichever category you want to tell. Just she's a poor
37-year-old.
responder.
Okay, sir.
And she's 37.
So, sir, I want to know about कितने IVF हुए हैं, कितने egg collection हुए हैं, कितने embryo transfers हुए हैं, whether
No, she just has come to you. She says, can this help me out or not? What is your say on this
No,
PRP and
IVF
stem
has
cells?
been done in the past, nothing.
It has been done. She had a failure. 2 or 3 cycles had been done.
Okay. So now what I want to approach this patient as a compassionate and experimental approach means now she has undergone IVF, she has not got the results, and she might have been told about the donor egg, and she has come with an expectations that I might help her with her own self eggs.
Yeah.
So based on some meta-analysis that PRP and stem cells do improve the microenvironment of the ovaries and help in good folliculogenesis and prevent follicular atresia, I can offer her this approach based on this meta-analysis with limited number of patients.
Have you tried, Neeti?
Yes,
Have
ma'am.
you done yourself anytime? Any of the
Yes.
patients?
Yes, ma'am. I do PRP for the patients. I have done stem cells for the patient as well.
Oh,
Advanced stage may we have not got that much good results, but PRP in some cases we have got good results in our patients.
But I
This was
think
a
we
study.
need to counsel the couple that it is only experimental and it is not there in the guidelines. It may be useful, but it is still a research-based tool.
Absolutely.
That counseling must go with the patient, and we do not know the long-term risks which may be there,
Yeah.
because some of the studies are showing cancers or
results.
diseases.
So this was a meta-analysis which I had taken out. This has been published in 2024, and they had 13 studies and 1,289 patients were included, and they wanted to see the outcome as well, ART outcome, as well as the improvement in ovarian reserve markers. And then that was and they had measured these outcomes 2 to 3 months after the PRP was done. And what was the result was that it improved the ovarian reserve markers with increasing AFC, serum levels of AMH and day 3 E2, and decreased levels of day 3 FSH. That was their conclusion. In addition, the treatment improved the ART outcome as well through the increasing number of total oocyte, number of M2 oocytes, and number of cleavage stage embryos, and number of day 5 embryos in POR. So that was the study which had mentioned all this. And regarding the stem cells in poor responders, they also said this was another systematic study. This was another study. I think it was not a systematic study done on 17 patients who were poor responder, and ovarian infusion of bone marrow derived stem cells was done. And their outcome was also AMH and AFC count, which they had seen. And they also came to this conclusion that This optimized the mobilization growth of existing follicles, possibly related to the fibroblast growth factor 2 and thromboprosin 1 within the apheresis, and it improved the follicle and oocyte quantity, enabling pregnancy in women who are poor responders, previously limited to oocyte donation. So
But
that are
did
the two
not
studies.
increase the clinical pregnancy rate or live birth rate.
I
That
did
is
not
why
mention that in this study. They just commented on the quantity. That is what they did.
in the IFS guidelines, we did extensive research for POR, and there we
I
found
do agree with you.
that you were there in the.
Yes, very much. So
Yeah.
that's the end of the panel.
So,
thank you so much.
Thank you.
So, regarding the PRP, can I share
Yes.
this thing? So basically, whenever there are patients extreme poor reserve and they're asking me about PRP, I tell them it is experimental. And
Yes.
since injecting it will be an invasive technique which is under anesthesia, I wouldn't like to do any experimental thing with so much of invasiveness and anesthesia involved. So at the time of their first egg pickup, let's say if they are going embryo pooling or anything, then this is what I am doing in my practice. If they are going egg pickup, at that time I tell them that maybe you are already under anesthesia, we are already putting a needle to pick up the oocyte, and that might as well put some PRP as well for in future it might help you. This is what I have been doing.
Very good idea. Very
That's
good
what we
idea.
also do. After the first pickup, we infuse whatever PRP we have prepared at the time of pickup only, because the
At the
needle is
time of
already
pickup,
there.
yeah. Also
at the time of
safe.
pickup.
So you are doing it the poor responder?
Yes.
Poor responder patients you are doing?
Poor responders.
Any cutoff of AMH?
No, I don't think
0.1
that
or
we do,
follicles.
like, we don't take AMH. We are not doing AMH that much also. It is mostly very selected cases we are doing AMH. But yes, when we are getting less oocytes and we see that, it can help the improving the microenvironment, like Neeti said. So we are, at the time of pickup only, we are infusing the PRP there.
Are you also doing for thin ET, Dr. Rashmi and Dr. Nisha?
Yes.
Hysteroscopic installation intrauterine?
I am doing hysteroscopy as well as the normal thing. The normal intrauterine installation we are doing for 6.5, 7 types. But if it is very thin ET, we have done with Dr. Vasanti, and she's preparing the stem cells and all. Along with that, we are doing hysteroscopic insertion. But that is a different. We take a proper consent and everything, and we do it in 2-3 sittings. Out of that, one sitting is hysteroscopy. Then next month it is just intrauterine. Then before transfer it is done. So there is a
Thank you
proper
so much,
protocol for
Nisha.
that.
Thank you. And I want just sir to have a final comment now. Sir, can I have a few words from you?
Let me congratulate all the panelists. They have been given very good input, and we are all wiser about the use of AMH in practical cases. I must thank all of you. It has been a pleasure listening
Thank
to
you so much, sir. Thank you for the
so much, sir.
opportunity.
I
Thank
think
you
the
very
best
much,
is
KT sir, Dr. Surveen and Dr. Renu.
Thank you.
Thank
I
you.
think the
Worked
best
very
is
hard.
use of AMH in male
Yes,
Yeah.
this is
facilitating.
absolutely an eye-opener.
That was a newer part, yeah.
Eye-opener, and also in menopause and predicting how it is going to reduce the fertility chances, prognosis. So that was very nice.
Thank you.
Something new.
Thank you so much, sir. And
Thank you,
thank you
Dr.
so much,
Surveen,
panelists, for
making
your
us
all your
available.
inputs. Thank you
Thank
so
you,
much.
Renu.
Dr.
Thank you,
Renu.
so much.
Thank you.
Thank you,
So
everybody.
much.
Surveen, you are there?
Thank you.
Yeah,
Hi,
I'm there.
Surveen.
Yeah, I'm there. Thank you.
Do you want to say?
Yeah, I
Yes,
want to
Surveen.
just thank Chaitra from Karnataka IFS chapter secretary, and Yogita from Himachal chapter for joining hands with us. Thank you so much.
Thank you,
And
And I
hope to have
thank
more
all of
PMH
you
with
for
you.
being
Much for
here.
giving us
And
the
thank you all
opportunity.
faculty, delegates, everyone. Renu, anything you would like to say? Sir would like to say anything?
We have done.
We have done. Thank you so much,
Dr.
sir, for being
Surveen,
there
this
with
will
me.
be,
Thank you,
Dr.
sir.
Surveen, this will be available on our website, right? If
Yes.
anybody wants to go through the
Yes,
materials.
absolutely. And
And I
lastly,
thank
thank
all
you,
the
Akanksha.
participants who are there with us. Thank you so
Thank
much.
you
for
so much, ma'am.
Thank
so
you,
much,
Akanksha,
Rashmi
for
ma'am.
Good night.
doing the
Thank
MC
you.
part. Thank you for conducting it so well. Thanks.
Thank you, ma'am, for
Thank you
giving me
so
the
much.
opportunity. And I
Bye.
look
Thank you.
forward to attending future master classes also, ma'am.
Yeah, absolutely. You're on board now.